Remember when you were young, you shone like the sun. Shine on your now there's a look in your eyes, like black clouds in the sky. We start in 30 minutes.
Ще
Sabarahu,
додаємо
you
на
need to mute. You need to
чи
mute.
не?
Okay, I got you. I got you. Urso, I need to mute you or remove you, whichever one. Can you mute there, Urso? Urso, can you mute, please? Oh, there you go. You took your microphone off, I guess. Okay, thank you.
Başla. Onları zırhlayacağım.
Hi, John. John, can you see me? Hello? Hello? John, can you see? Can you hear me?
I keep the picture up to keep it so they can.
Hello?
Yeah, I can see her.
Okay. Tell me when do you want to start, John? I mean, I will start.
Okay, I can.
John, can you see me? Hello? Hello? John, can you see? Can you hear me?
I keep the picture up to keep it. So
Hello?
yeah, I can see her.
Tell me when you want to start, John.
Yeah, I can.
John, can you see me? Hello? Hello? John, can you hear me?
I keep the picture up. Hey,
Yeah.
you can hear me. How you doing?
Listen, I think there is a loop playing on.
There's a what?
loop of my voice going on.
Okay.
Because I can still hear that going on.
I'm sorry, I don't understand.
You know what? Yeah, see? Can you hear me?
Yes, I can hear you. Yes, I can hear you.
Now there's a loop of our voice going on.
Yeah. I'm turning it off now because I usually keep the live screen of the YouTube, which is 15-minute delay, but I turned that off.
It's okay now, I guess.
Yeah. Well, yesterday you picked out. Remember, we were having feedback problems, and the tool had two devices open, so that was that was the right thing to close that. You had two inputs.
Let me know when you want me to start, and I'm all ready.
Yeah. Okay. Let's go now. Okay.
Right.
10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. We have another episode of the Daily Doses of Neurosurgery Education, trying to fill a void during these times with both Hype Sharian today and Atul Goel. So we'll start right off with Hype. Good morning, Hype, and thank you.
Morning, John. So today we're going to continue yesterday's carotid, and also, I mean, I have figured out how to do the pointer with iPad today, and then we will go on to see another paraclinoid aneurysm and a few cases. I mean, in 1 hour, a few cases that I can show you, so that we learn something every day. So after that, we will discuss this, and then we'll hand it over to Professor Goel. So let me share my screen right away. Screen, John?
Yes.
Right. So yeah, so yesterday we were talking about the carotid. We talked about 3 vertical segments. That is, can you see that pointer there?
Yes, we can.
Okay, fantastic. So that is what I have figured out. So I can use my Apple Pencil and get this pointer there. So that is C3, that is C5, and that is C7. These are the 3 vertical components of the extradural carotid: C3, C5, C7. Now C3 is paracellular carotid, C5 is paraclival carotid, and C7 is parapharyngeal carotid. Now, when we join that, so you have the C3 and C5, that's the paracellular and paraclival carotid. When you join it, you get a horizontal, almost horizontal segment. That is a C4. C4 is a horizontal intracavernous segment. And then when you join the paraclival and the parapharyngeal carotid, you get the C6 carotid. That is the petrous carotid. Okay, so that is all the carotid is. So you have paracellular, you have horizontal intracavernous C4, then you have paraclival, then you have the petrous, and then the parapharyngeal. So the endoscopic guys are going to see all the vertical segments. So first thing that they see parallel to the sphenoid sinus is the C3. And then this is the region of the foramen lacerum. And so you drill a little bit more down, so you'll see the paraclival. And if you do sublaceral drilling, and if you are going to do sublaceral drilling, you're going to see the parapharyngeal carotid. So these are the 3 segments of carotid that you will see. The petrous carotid and the horizontal intracavernous carotid you can actually see in an endoscopic view also, because these are not really straight. They are coming at an angle to you. So that is why you can see them. Right. So adding on structures now.
मेरा वीडियो ऑफ कर दिया मैंने.
So now you can see I'm adding on structures. That is the GSPN. Joining the lesser Petros. There's somebody talking. Can we?
Yeah, I got that. I got that. I just did it.
So that is the GSPN, which is parallel to the Petrus carotid. You will see that when we today's dissection, we'll see that. And then you will see that GSPN, and then you will see the Vidian nerve at the foramen lacerum. This is the foramen lacerum region where the petrolingual ligament is there. And you will see lateral to the carotid, that is a C5 C6 junction. You will see the Vidian nerve. It's a very good marker. And in fact, you can also see the V2 there. The V1, V2, V3. V2 will be going into the infratemporal fossa. I mean, not to the infratemporal fossa, the pterygopalatine region, and V3 will be going into the infratemporal fossa. So you can see that, and then you can see the third and fourth nerve also. So you will have the clinoid there. You will have the clinoid in that region, and you will see also the third and fourth nerve there. Now, when the dissections are coming, you will see that. We are adding a little bit more structures. That is the petrolingual ligament at the petrous paraclival carotid junction. Then you have the clivus there. That is the posterior clinoid process, and that is the cochlea. So the C7 carotid actually ascends in front of the cochlea. Maybe when I show you a translab approach, an extended translab approach, I can show you if you drill anterior to cochlea in the facial recess, you will see the promontory and then anterior to the promontory. So the facial nerve is going to be there. And if you, in the facial recess, first thing you will see is the promontory. And then if you expose a little bit more, drill a little bit more, you can see the carotid canal. That will be the C7, vertical petrous or the parapharyngeal carotid region. Okay. And there you will have the anterior clinoid. That will be the posterior clinoid. So you have paracellular, horizontal intracavernous, paraclinoid, petrous, and parapharyngeal. That is the cochlea. That is the GSPN. That is your petrolingual ligament. That is your clivus. That is your posterior clinoid process. Okay. And that is your gazetting ganglion. That is your V1, V2, V3. And medial to this V1, the sixth nerve will come and go into the Doralus canal there. Okay. Right. Now let's see this in a little bit more schematic form. I am asking you guys. So what is that? Anybody answer me?
Parapharyngeal, carotid, cochlea.
Yes.
Cochlea.
What is cochlea? Excellent. And what is that structure? This is something new. This is a tube running from the medulla into the fat. Eustachian. What is that carotid which is running parallel to the eustachian?
Petrus.
Excellent. That is a petrous carotid. And what is that? What is that green ligament there, which is between
Petrolingual ligament.
Petrolingual ligament.
And what is that carotid?
Paracellular.
Paraclival.
Paraclival.
So what is this? What is this structure? That is the clivus. And
Gruber's
what is,
ligament.
yes. And what is that?
Seventh.
That is the posterior clinoid. And that at the C4, C5 junction, I'm going to show you that artery actually today. At the C4, C5 junction, you will see the meningohypophyseal trunk. Okay. The meningohypophyseal trunk sometimes feeds dural AV fistulas around the in the superior petrosal sinus. So if there is a dural AV fistula around the superior petrosal sinus, so if there's a large petroclival meningioma, if there is a tentorial meningioma, this artery is going to be very large. So I'm going to show you today how we handle one of those cases. Okay. What are these two nerves?
Optic oculomotor.
No. Oculomotor and the fourth nerve. Optic nerve is here above. So that is the clinoid process. That is the intradural C2 carotid. That is C3 carotid. That is a paracellular. This is V1, V2, V3. Everybody got these structures?
Yeah.
Yes.
In the WhatsApp group, I'll ask Hira to share my chapter. There is an Atlas of Cellular, Supracellular, Narayan's book. We have a chapter, and that chapter contains all this classification. This is our classification, our modification of the classification of carotid, and it's a very, very simple classification. And to learn skull base with this classification is extremely easy. Now let's go into the structures actually. Okay, right. Now I'm sure you'll be able to identify all this carotid, all these structures. Now let's see, what is that structure? What is that?
Optic
nerve.
Yes. What is that artery?
ophthalmic artery.
Ophthalmic.
Excellent. And this is intradural. So what is that thing?
Distal dural.
X. And what is that?
Proximal dural.
Excellent. So you have the transitional C3 carotid there, okay? And then now that is a C4 carotid. Now you have C5 carotid. You see on the top of C5 carotid, there is a branch there. Can you see that branch? It's cut off, but there is a branch there. Between the third and the fourth now, can you see that branch? Can you see that branch there?
Yes.
Yes.
Yeah. Which branch is that, do you know?
Meningohypophyseal.
Meningohypophyseal trunk. Yes. What is that ligament?
Petrolingual.
That is, I stumped you. That's a googly. Okay. That is a Doralus canal. And so that what ligament? That's a Gruber's ligament. Okay. So you have the Gazerian ganglion. You have the okay, that is a Gazerian ganglion. That is V1, V2, V3, and medial to the V1, you have the sixth nerve coming in from the Doralus canal, from the posterior fossa. So this is the Gruber's ligament, and then you have the sixth nerve coming in there. Third nerve, fourth nerve. Okay. So, and the V3 is going into the infratemporal fossa. You can see the internal maxillary artery. Okay, IMAX. What is that now? This is the C6 carotid. This is the Petrus carotid. What is that now?
Facial nerve, GSPN.
Yes, excellent. And what is that structure? I told you the parapharyngeal carotid will be coming like that. So what is that structure? Anterior to the facial nerve?
Geniculate ganglion.
Yes, of course. That is a geniculate ganglion. Anterior to that, I mean, I told you anterior to that, anterior to the cochlea. Sorry. I told you anterior to the this is the cochlea. So the C7, C6, C7 structure, the C6, this is the Petrus carotid, and the parapharyngeal carotid will come like that. Okay. The eustachian tube is here. Okay. The eustachian tube is here, parallel. And that is the facial nerve, and that is the semicircular canal. Posterior to the IAM, that's semicircular canal. This is the cochlea. You will see all this in this dissection today. Okay. So, well, so you have identified almost all the structures there, everything. Okay, let's go. Okay, now we are going to see a paraclival carotid artery aneurysm. Okay, I mean, sorry, not paraclival. I mean, C3 carotid artery aneurysm. Okay, it's a transitional aneurysm. You can see it is below the clinoid level. Okay, it's below. Beg your pardon? Can you see this now? Everybody?
Yes.
Okay, so this is the temporal lobe. This is the frontal lobe. So what I am doing is I have taken the temporal lobe away. And so that is the cavernous sinus, and medial to this is the superior orbital fissure region. That is the cavernous sinus, and that is the clinoid process, okay? Clinoid process. So Dr. Goyal was talking about damaging the third nerve. If you are putting too much traction while trying to dissect the clinoid process out, this is the third nerve. Third nerve is going to be here. It's going to the superior orbital fissure. And that is the third nerve going to be. This true cavernous membrane is intact, and I am drilling the clinoid medial to the cavernous sinus here. Okay, I have opened the frontal temporal angle, and I am drilling the clinoid here. Okay, so this is going to be, yesterday I showed a completely extradural drilling. This is going to be an intra-extra drilling. I mean, a hybrid, which means I am doing most of it extradural, but the strut, I will take it out intradural.
आवाज आ रही ना वापस शायद
इधर से म्यूट कर देता हूँ।
नहीं हो रहा
Are you seeing? Are you guys seeing this?
Yes, very clear, sir.
Yes.
Very good. So we are drilling out the clinoid. Most of the clinoid we are going to take out, except the strut. Okay, a little bit of the strut. Now that clinoid is empty. Now that is the cavernous sinus. This retractor gently on the temporal lobe. So that is the third, fourth complex is there. Okay, it is under very high magnification, extremely high magnification. Okay, so I am drilling between the frontal lobe, temporal lobe, and the cavernous sinus. I am drilling inside at the clinoid, because this angle is strange, because this angle is the only angle which is suitable for me to clip this aneurysm. So I am taking off all this. My suction is protecting my cavernous sinus. That is the frontal lobe. That's the temporal lobe. Okay. So I am thinning out the cavernous sinus. I mean, by thinning out the clinoid bone completely. Usually it is a shell actually, but here it was a lot of solid bone. So now that is the optic roof. Okay, can you see the extradural optic roof? Yes?
Yeah, we can see.
Yes, that has been drilled out. Now here is the carotid, and that is extrude. So I am taking off that part also. Okay, so that is a frontal temporal angle. Okay, so I'm taking out all that. This is, I'm using a 2 millimeter drill here. My suction on this side is protecting the cavernous sinus. So that is a optic. This will be the carotid. That will be the cavernous sinus, and this will be the this will be the clinoid side. Optic strut is not taken out. So that is the optic, and that is the the carotid with the aneurysm. So I'm cutting the distal dural ring. Can you see, guys? Can you see?
Yes. Yeah, clearly.
I'm cutting the distal dural ring. Yesterday, I went and cut the falciform and then came laterally. Here, this is not practical. So I need to cut the distal dural ring straight here. And then with the aneurysm right there, I'm drilling the strut. I'm drilling part of the clinoid and the strut. Okay. So you must understand the optic nerve is there, carotid is there, and that is between that is the strut. So little bit of lateral clinoid and the strut, I have to take it off, keep on laterally and medially going on, keep on drilling. Again, this is just painting, okay? This is not really drilling, but again, as somebody asked yesterday, you have to maintain water, okay? You're drilling very near to the optic nerve. So you must maintain water. That is the aneurysm there, okay? That is the aneurysm there. So you are literally, you have no dural protection here. So somebody asked me yesterday why I prefer intradural versus extradural. I mean, it's all different ways, okay? It's like a different way of dress. One South Indian would wear one dress, the North Indian would wear one dress. Whatever is appropriate for that time, you will take it, okay? It's not like a, obviously you don't want to get into a beach and wear your three-piece, right? So depends, huh? That is how it is.
Okay.
Excuse me for a moment. My dad is calling. That's more important than this. So I will resume 1 second. Hello? 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 Okay. Right. The call dropped. Right. So we are going ahead. So that's a 2 millimeter drill, and I'm completely drilling it off.
Yes.
You can see the aneurysm there, and I'm doing an intradural clinoidectomy right now. So I'm keeping on cutting towards the cavernous sinus roof. Okay. As I drill more and more clinoid, I am cutting distal dural ring and cutting towards more and more. You see, this carotid is going to lead me into the cavernous sinus. You understand that? Because we told that C2 carotid will lead you into C3 carotid, right? So C2 carotid is intradural, C3 carotid is extradural cavernous. So we have cut all that. Now we are seeing this huge aneurysm there. All right. So that is a cavernous sinus roof there. You can have cavernous bleeding there because you've opened into that. Okay. And now you control that bleeding with a little bit of Surgicel, and you can see this huge aneurysm. All right. Please give me 1 minute. Please give me a minute. Hello. എന്തു പറ്റിയ ഒന്നും പറ്റിയില്ല ചാ, കാലിലൊന്നും പറ്റിയില്ല അച്ഛാ. ഞാൻ ഒരു ഓൺലൈൻ ടോക്കില്ല അച്ഛാ. ഞാൻ ഒരു ടോക്ക് കൊടുത്തിട്ടിരിക്കുക. ഞാൻ തിരിച്ച് ഒന്നും പറ്റിയില്ല, കാലിലൊന്നും പറ്റിയില്ല. ഒരു കുഴപ്പമില്ല, ഒരു കുഴപ്പമില്ല, കാലിനൊരു കുഴപ്പമില്ല. ഞാനൊരു ഓൺലൈൻ ടോക്ക് കൊടുത്തോണ്ടിരിക്കുക. അത് കഴിഞ്ഞിട്ട് ഞാൻ വിളിക്കാം. ശരി, ഓക്കെ ഓക്കെ. All right, sorry for that.
No problem.
Yeah, so you can see the C2 carotid, the C2 carotid, the C3 carotid going into the cavernous sinus. That is the cavernous roof where we have cut the distal and the proximal dural ring, and that is the aneurysm. It's clear to everybody? Yes? Clear to everybody?
Yeah.
Yes.
Okay. So we are going to try and clip this aneurysm. But what happened is when we tried to clip this aneurysm with a single clip, it ruptured. Okay. The rupture is not there right now. I mean, I will show you. If you want to see the entire rupture video, you can see it. I can show it. But, you know, we have neck control. So once it ruptures, it becomes very easy. So once it ruptures, you can see how the aneurysm is. It's very lax, and, you know, it's very easy to clip it. So once it ruptures, we got neck control. We put a pressure on the distal, and then now we have clipped that aneurysm. Okay, single clip. That's all. All right. Well, that's our dissection in Malaysia, where Dr. Al-Mufti had come to watch. Right. So this is a you know, intracavernous feeder. So which means MMA was feeding this. This is a dural AV fistula, which was being fed by MMA as well as the meningohypophyseal trunk. Okay, so the MMA was completely coagulated. So we have gone subdural, subtemporal, and as well as we have dissected all of the cavernous sinus. And I'm going to show you the cavernous sinus dissection. So you can see the GSPN there, and then you can see the petrous ridge there. That's the petrous ridge, and that's going to be coagulated right now. And then we'll go for the intracavernous, between the Parkinson's window is going to be open now. We're going to open the Parkinson's window. So you can see the GSPN there, the Dowling covers a rhomboid there, and you can see the V3 there. The dura propria is being dissected now. You can see the V3 there. You're going into dissecting the V3 and going into the interdural plane. This is exactly what you would want to do for a trigeminal schwannoma. You can see that is a V3. That is a Kawashi's rhomboid. And you can see that is V2. That is V1. Okay. That is V1. That is V2. V3 is there. So this is V1. So that is Parkinson's triangle. Okay. That is Parkinson's triangle. So we open the Parkinson's triangle. And when you open the Parkinson's triangle, you see the C4, C5 junction. I will show you how it works out, how it comes. You see that? That is, can you see the V1? Can you see the V1? Yes?
Yes.
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 We can.
And that is the fourth nerve. Okay? And this is the paraclaval carotid turning into the horizontal intracavernous carotid. And that is where your meningohypophyseal trunk is. Okay? That is your meningohypophyseal trunk. So that is C5, that is C4, that's paraclaval carotid becoming C4. And this is what you will see in the window between the V1 and the fourth nerve. So that's exactly what you're going to see now. I put this figure because it's difficult to understand. So you will see that is V1, that is fourth, and that is the carotid. Okay. And this is the meningohypophyseal trunk. Okay. And it is this branch. So that is the carotid, and it is this branch that it's a large branch. So that is what people ask me why I don't bipolar here, because I don't bipolar here because do you know why I don't bipolar here? What nerve runs medial to V1?
Abducent palsy, to prevent abducent
Yes.
palsy.
No. Okay, you will have a fixed nerve palsy. So you don't want to bipolar there. Okay. And if you bipolar, if that vessel snaps from the carotid, then you had it. Okay. Already you are inside the cavernous sinus, and then you don't want any vessel snapping. So that is this is pure intracavernous surgery. So this is C5 carotid, C4 carotid is here, and then you have a meningohypophyseal trunk. So you're using 2 microclips. It's under very, very high magnification. So that is a V1. See, that's a V1. That is a fourth nerve. Fourth nerve is here. This is the window. This is the Parkinson's triangle. Classical Parkinson's triangle. You've opened and then you clipped off the meningohypophyseal trunk. Okay, right. Let's go. So this dural AV fistula, now you can see the carotid there and the cut off meningohypophyseal trunk. You can clearly see that because of the V1, you are not seeing it, all the carotid. You are seeing only part of the carotid, and you can see the cut off view. So this dural fistula was being supplied by the middle meningeal artery and the superior hypophyseal artery. Once you took off those vessels, then it is a very easy thing to handle the dural AV fistula. Right. Right, so we will also now see another clinoidectomy, that is a posterior clinoidectomy. Okay, this is something that I like. So you can see this is the optic nerve. Okay, this is the carotid, and the carotid comes here, and then there is A1 here. That is carotid, and this is A1. So the membrane of iliaquous region is completely covered by this posterior clinoid. So if you want to do a basilar tip aneurysm or something, you will have no space at all here. You can see 2 perforators coming here. You have to be very careful about these perforators. These are 2 perforators. Okay, these perforators supply the supply the optic nerve. So you have to be very careful. So you're using a 1 millimeter drill under very, very high magnification. You're drilling the posterior clinoid off. Okay, so you're drilling the posterior clinoid between the optic nerve, the carotid, and the A1. So you have a 2 into 3 millimeter window. Okay. Once you drill off this posterior clinoid, then you can collapse this dura, and then you'll get this much space. Okay. So that is the thing that you will see. That is a carotid artery. It's a third nerve. It's a basilar, P1, SCA. This is 1, P1, P1, and SCA. This is exactly what you will see. All right. So this is what you will see now. Okay. So that is the carotid, that is the optic nerve, that is the basilar, that is P1, that is superior cerebellar artery, and that is the A1. Okay, this is an old video. So that is what you will see. All right. Now, shall we stop here and do the rest later? Because we have a lot more to go, and we are already at 5:47. So maybe I'll take questions from now, and tomorrow, or maybe some other day, we can continue on with the dissection part. Or do you want me to continue on, or you let me know as to, I mean, I think.
Continue.
What do the panelists want? What do the panelists want?
Continue.
Continue.
Okay. Right.
Okay.
Please
Right.
continue.
So, yeah. Okay. So you see, what you are seeing right now, what I'm trying to show you is that, you know, I have classified skull-based maneuvers into 3. See, this is something in the skull base. If you want to get it, what do you want to do? You want to open up this part, right? This is called the sagittal unlocking. So we are going to see how it is being done. So when you remove the bone there, this is sagittal unlocking, and it's very easy to get in there. You see, that is called sagittal unlocking. Okay, this unlocking, it's called sagittal unlocking. It's completely by sphenoid ridge removal and also by anterior clinoidectomy. And now axial unlocking, see, this is the temporal lobe. That's the temporal lobe. Cavernous sinus is here. Okay, so when you remove the temporal lobe away from the cavernous sinus, you remove the temporal lobe away from the cavernous sinus, peel off the temporal lobe away from the cavernous sinus, you're getting access into the posterior supracellular cistern, that's interpedunculair cistern and everything. You're getting beautiful access into. That is Dolling's technique. Okay, transcavernous or pericavernous peeling. All right. So that is called axial unlocking. So I classify it as axial unlocking. All this is given in the chapter. This is axial unlocking. Okay, you've taken this temporal lobe laterally. So this is axial unlocking. Okay. Are you understanding both sagittal and axial unlocking?
Yes.
Yes.
Yes,
And
yes.
the last unlocking is Sylvian dissection. It is intradural, and it is called oblique intradural unlocking. So you do these 3 unlocking, the skull base is completely open for you. Now let me show you. That is the orbit, that is the frontal lobe, that's the temporal lobe. Okay, so you have frontal lobe, temporal lobe, and the orbit, and you have orbitomeningeal band there. Okay, that is the orbitomeningeal band. So I am going to peel off the temporal lobe away from the cavernous sinus. So that is axial unlocking. So that is a true cavernous membrane. That is a superior orbital fissure. Exactly what you saw me doing in that paracavernous paraclinoid aneurysm. Okay, holding this temporal lobe, and so that's a superior temporal. That's just a superior orbital fissure, and that is the cavernous sinus. Okay, what you saw in that case, exactly what you saw in that case. And I will show you once I cut the orbitomeningeal band, you will see how I will show you the clinoid process now. So that's the cavernous sinus. It will not bleed because you have preserved the true cavernous membrane.
And how neurosurgery was involved in this effort. Very significant participation because of
John?
Yes.
Somebody talking?
I'm sorry.
And then emergency
No problem.
I'll get on. It's like a bleeder. I'm just going to find it.
Okay.
Got it. Got it.
Okay. Right. So I'm cutting the orbitomeningeal band there. Okay. So you can see the temporal lobe, frontal lobe. I'm doing a sagittal and axial unlocking so that the frontal lobe was supposed to be like that and the temporal lobe was like that. So I am taking off that curve in 3 dimensions away. So now getting into the cisterns, into the base is rather easy for me. So that's the orbitomeningeal band. I'm cutting towards the superior orbital fissure because I've identified the superior orbital fissure I know where the nerves are going, so I can cut all the way up to there. That's, I'm cutting the orbitomeningeal band, keeping on cutting, keeping on cutting. Right. So once I cut the orbitomeningeal band, you see, that is a fourth nerve, and medial to that is the third nerve. Okay, that's a clinoid triangle. That's a clinoid process. Okay, how we are going to do take off that clinoid process? Don't take it off like that in a surgery, yeah. But it's cadaver dissection. So I'm showing my colleagues. One of my colleagues is taking it out. It's very easy because I've opened out the entire clinoid space. You see, it's so easy now to remove that clinoid. Okay, see, it's so easy because you're seeing everything. Okay, that's a clinoid triangle there, the entire clinoid triangle. Okay, we just dissecting it off. So that's a third nerve. That is a third nerve, and that is a fourth nerve. The fourth nerve overtakes the third nerve to come on top, the superior orbital fissure. Okay, and that is a carotid. That is a carotid there. Okay, and there will be the optic nerve. All right. Once I drill off this, you will see the optic nerve. Now, I just wanted to show you. Okay, so that's the strut. That is a strut. That is what we are drilling in the first case that I showed you yesterday. That is the optic nerve. Okay, that is the optic nerve. That's a carotid, and what I showed you was the strut. So this is V1. That is V1. That is the fourth nerve. So this is the Parkinson's triangle. Which segment of carotid am I seeing now? Which segment of carotid?
C4.
4-5 junction.
This is C4 and this is C5. And what nerve am I hooking it out? What nerve am I hooking out? Medial to V1. What nerve is that?
Abducens.
Abducens, absolutely. So that is V1. This is the Gazerian ganglion. Okay, that is the abducens now. This is C5 carotid, and that will be C4 carotid. Okay, that is the third and the fourth nerves there. Okay, excellent. So that is V3, and behind V3, I am identifying the Kawashi's triangle. Okay, that's a Kawashi's triangle. So sometimes petroclival meningiomas, this is a beautiful approach. You don't have to be this extensive for all petroclivals and everything.
I'm sorry. Okay.
Okay, so now we are drilling the Kawashi's triangle. Okay. We're drilling the Kawashi's triangle. That's the Kawashi's triangle. First thing I will always drill and show you is the carotid. That is the first thing that you want to see. So once you drill that, once you drill around that carotid, you are safe. Okay. Once you identify that carotid, then you are safe. Somebody was in my field. I don't like that. So that is a carotid. Can you see that? That is a carotid. I'm removing. I'm eggshelled that portion, and then I'm showing you that's the carotid. Can you see the carotid? That is the carotid. Can you see me moving the carotid?
Yes.
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 That is Petrus carotid, C6 carotid. Okay. So that is the Petrus carotid. And once the Petrus carotid is identified, then I can go all the way. That is the Petrus carotid there. That is V3. That is GSPN. I can go all the way up to the IAM and even behind the IAM. Okay. So post-meatal drilling is also positive. Possible. I just have to preserve the cochlea. I can decorticate the cochlea, but I have to preserve the cochlea. Okay. So that is the C6 carotid. Now I'm taking off the whole. Yeah. Now I have. Sorry. We have. Okay. I don't know why it's going back. Okay, right. So now you have the lateral pons there. That is a trigeminal nerve. I have opened the Meckel's cave. This is called unlocking the Meckel's cave. So the Meckel's cave is unlocked there, and that is a posterior fossa incision. Okay, so once the posterior fossa incision is done, you can put in a stitch like that, and that is anterior pons, and that is lateral pons. Okay, you can see IAM. If you see, if I take this dura, you will see the IAM, facial nerve coming there. So you can see that is the, what nerve is that? What nerve is that?
Optic.
Yes, absolutely. So you can see all the way from optic nerve to eighth nerve. Okay. So you can see the optic nerve, and then what nerve is that getting into the roof of the cavernous sinus?
Third nerve.
Third nerve. Excellent. And what nerve is that?
Trigeminal.
That is the fifth nerve. And that, what nerve is that? That is the IAM
Sir?
open. That is the IAM open. That's the facial nerve, and
Okay.
that's the ICA loop.
Seven and eight.
And that is
complex.
that is posterior pons. Okay, so all
Okay.
the way from second nerve, okay, from second nerve, all the way from second nerve, third nerve, fifth nerves. So second nerve, third nerve. Let me just stop this for a minute. So you have second nerve, you have third nerve, you have fifth nerve, you have seventh, eighth complex. Okay, sphenopetroclival meningiomas or things like that. You need a wide exposure. This is what I mean. Otherwise, you except for that, you really don't need this exposure. It's just to enjoy the anatomy. All right. So, but you must know each part. So this is actually a case where we are doing that. So that is the orbitomeningeal band, just like what I showed you. We are cutting it. Okay, under very high.
Right or left? Right or left eye?
Huh?
Right or left?
Okay, so you guys will have to tell me now. All
Right
right.
side.
So what is that? What is that? Frontal lobe or temporal lobe? See, this
Frontal
is
lobe.
cavernous sinus.
Temporal
Yes,
lobe.
absolutely. Yes, this is the front. This is the temporal lobe. This is the frontal lobe. So once I cut, so this is the right side. So I am cutting the orbitomeningeal band. Once I cut the orbitomeningeal band, you can see the clinoid. Can you see the clinoid?
Yes.
Yes. Now the
Yes.
clinoid is being uncovered. Okay, once the clinoid is being uncovered, I am going to dissect more of the cavernous sinus. Okay. So I'm taking stitches, and that is a clinoid. That is a clinoid. Okay, that is a cavernous sinus there. Okay, just like we did in the cadaver. This is the cavernous sinus. Okay, that is the temporal lobe. Temporal lobe is peeled backwards from the cavernous sinus, and that is a clinoid which is being taken out. So this is obviously not an aneurysm. This is why I'm going very, very fast here. Maybe a tumor or something. That is optic, extradural optic nerve. I'm eggshelling that bone over the extradural optic nerve. Okay, I take off all that bone in that region so that you get excellent sagittal unlocking. Once you get sagittal unlocking, you can. That is the base. You see, that is the base of the brains. You know, if you are talking about skull base, that's the base. All right. So if you open there, you're getting into the suprasellar system. So that's your clinoid being coming out. That's your clinoid coming out. Eggshelling it completely. Not much of force, just painting it over. So the clinoid is going to come out right now. Yes. So that is the extradural optic now. Okay. And that will be where the carotid is. Okay. That will be where the strut is. Obviously, I don't need to remove the strut in this case. Strut has to be removed only in aneurysms. So I am that clinoid. That part of the optic roof. That is the carotid region. Okay. That is the cavernous sinus region. That is the cavernous sinus. Okay. peeling a little bit more of cavernous sinus off. So this curve of the frontal temporal region has been completely unlocked now. You see that? So cavernous sinus is completely uncovered there. So if you want to get into the interpedunculair cistern or something for a basilar tip aneurysm, now things become very easy for you. So you must understand what this transcavernous approach is for. It is not for getting into the cavernous sinus, but of course, one function of it is to get into the cavernous sinus, but it is to take this curve off frontal lobe, temporal lobe. Now, frontal lobe, temporal lobe is like that. It's completely open, you see. This is the beauty of this approach. That's why Dolenz is a genius, you know. Professor Goyle, he devised this approach way before that. Apparently, I mean, I didn't know. So it's something to be proud for people of this region that Professor Goyle was doing this extradural approach almost in the same time as Wingo Dolenz was. I was lucky to give a lecture in Dolenz Institute when about 6-7 years back, and I was telling him about this approach, and he was very happy to hear that. But he told me that he had already started preserving the true cavernous membrane way before we even thought about it. I was thinking I was the first one to do that. That's what everybody thinks when we do something, but of course he was doing it. See, there is no bleeding at all. You see, that's a cavernous sinus. There's no bleeding. That's because I have preserved the true cavernous membrane. Okay. So that's a cavernous sinus. Okay. The temporal lobe is being peeled away from the true cavernous sinus. You don't have to get into the cavernous sinus. Like last case, you don't have to get into the cavernous sinus. So the transcavernous peeling here is only to take this curve off to get into the base. Okay. So it's a skull base approach. See, we're peeling it off. Okay, let us go forward. Okay, right. I will want you to show you this aneurysm. Okay. All right. So, God. Okay. Can you guys identify things here? Okay, let's start from here. The whitish structure that you see there is a mammillary body, okay? That's a mammillary body. So, okay, let's see. That is the PCOM coming down, and the PCOM is almost like the P1 here. And sorry, oh God.
Slipped off.
Sometimes, just like your surgery cases, you know, sometimes the unexpected happens. Well, all right. Okay, so that's the mammillary body. Okay, can you see the mammillary body there? That's a mammillary body. That's a basilar tip aneurysm. That's an aneurysm. Okay, an aneurysm which has burst 3 times. So I'm just taking off the clot of that aneurysm. That is a basilar. That is the third nerve. That is a PCOM P1 junction, and this is the another P1. You will see when you see the angiogram, you will understand. I'm just removing the clot off. Probably this is a very broad-based aneurysm, extremely broad-based aneurysm. You know. Okay, so I am just exposing all the clots, everything, seeing the aneurysm clearly. That's a basilar. That's a basilar tip. Okay, you will see now. So See, that is the basilar, that's the PCOM P1 junction, that is P2, third nerve was there, that is aneurysm. Okay, that is aneurysm. All right. So that's exactly what you're seeing right now. So I'm just bipolaring. That aneurysm is extremely broad based. So in this case, I would like to bipolar. No proximal control, nothing. Okay. You must understand I'm a bit crazy. Okay, fine. We are going into another aneurysm right now. This aneurysm, I will show you. If you're interested, I will show you what happened here. And this is another aneurysm this is not what I wanted to show you. This is, of course, an IC bifurcation aneurysm. But what I wanted to show you is there is another aneurysm there. Okay. Here we have done an intradural clinoidectomy. Okay. Tailored intradural. There is no need for extradural, complete extradural clinoidectomy. This is a PCOM aneurysm. So this PCOM aneurysm, you can see the clinoid there. So, and the tent there. So what you need to do is you need to do a tailored intradural excision. So after I clip this aneurysm, I will go and clip that other aneurysm. You will see that now. This is an IC bifurcation aneurysm. This is unruptured. So this is not extremely difficult, but the other one is the ruptured one. So you can see, I am seeing the AC there, and after that I'll clip off the aneurysm. And then once I clip that aneurysm, I'm going lateral. I'm going lateral. And that is a tailored clinoidectomy. That is a PCOM aneurysm which is ruptured. That's a tent which has been coagulated. And that is a carotid. That's the optic nerve. So that is aneurysm base. Once I get enough space, I'm going to put the clip on to that 1, 2.
Hi, Vlad is in the house.
Vlad is in the house?
Yes.
Yeah.
Okay,
Hello.
fantastic. Vlad.
Hello.
Hey,
Nice
Vlad,
to
good to
meet
see
you.
you, Vlad. Good to see you. I'm
to see
showing
you
them
too.
some. I'm showing them some of my crazy cases, Vlad. You might know all of them.
Enjoying.
Yeah. So that's the PCOM aneurysm, and that is what the tailored clinoidectomy cut. Okay, hey Vlad, imagine you came and that is supracerebellar infratentorial.
So I just came in time.
Yeah. I think you came and that video came in.
Yeah,
so
sure.
It truly shows that you're one of the big guys. Professor Goyal is also here. I mean, he was talking about supracerebellar infratentorial approach long time back. So he was, he was to tell you about it. Is Professor Goyal around?
Yeah.
He's there.
Okay, fantastic. Great. So this is a supracerebellar infratentorial approach. Here, what we did is, I thought of going lateral here, but if I went lateral, the pulvinar I thought would be in my way. I know Vlad would disagree. I mean, because he's very, very experienced. I was thinking the pulvinar would be in my way, and because this tumor is way more anterior than a usual pineal tumor. So that is why I thought I would not go lateral supracerebellar, I would go medial supracerebellar, so that I have a direct corridor from here, although it is very, very long corridor. And you must see this tent here. I should show you some sagittal pictures so that I can show you the tent here. This tent is really, really, okay, you will see the tent here. You see that tent here? I mean, I'll tell you, Vlad will be feeling pity for me. See that tent there? So this is not this is not a tent which you will be happy about for doing a, supra-infra. So this is what, so this is the tumor. So we're going to take it out. Now you will see what happened here. This is our last case. So after this, we are handing it over to Professor Goyal. So of course, I mean, you are taking off these veins, and this is the sinus and the tent being hitched up. I need a lot of stitches here because of course, I mean, with the tent like that, I would need a bit more stitches. I don't want to retract the cerebellum actually. So we are also putting stitches on the tent. You can see that. You have to be very careful with those stitches. So we are putting stitches on the tent so that that gives us a few additional millimeters. So that is a tent. That's the tent. Now we are going towards the free edge of the tent. So that is the free edge of the tent. Those are the two pulvinas. You can see the veins and the very thick arachnoid, which is usually seen here. But this arachnoid was a little bit more thicker than what we have seen. I'm sure Vlad would have seen many, many thick arachnoid. So this retractor is just sitting there. It is mobile. You can see it's mobile. It's just kept there. It is not retracting. I mean, it's not attached to anything, just kept there. So I'm cutting the arachnoid there. And once I have the veins, so that arachnoid is cut there. Those are the big veins. So you have the pulvinar on both sides. The vein of Galen and the internal cerebral vein would be anteriorly. So we have to get into the third ventricle, posterior third ventricle there. And that is where this tumor is going to be. So that is the endoscopic view. So we put in the endoscope and we saw the endoscopic view. And under the endoscope, we are taking out the first bit of the tumor under the endoscope. So and what I wanted to show you here is we are inside here and we're trying to take out this tumor. We tried the Cusa, but it's like a piece of eraser, literally like a piece of eraser, rubber. Okay. So Cusa, we put the Cusa on and it was mobile, but it was like rubber. So finally, that is a artery there. So you just moving off everything that's inside the third ventricle, you see. So I wanted to take off this tumor, but suction, of course, it was not suckable at all. I tried to bipolar it and cut it, but then I would have spent the entire day doing that. So it's literally like rubber. So then I decided I'm going to use an instrument that normally a lot of people won't use there, and that is a debrider. Okay. So we have the micro debrider. So we went in. Once I dissected that thing off, I mean, it was coming off nicely from. It was coming off nicely, but it was just not. I was not able to deliver it out because I didn't want to, deliver that thing out right through there because it would have caused huge damage. So I wanted to break it. So breaking it was only possible with a, debrider. So we got the planes out, we defined the tumor, and then this was attached to the velum interpositum. So it came out as a meningioma. So it was a velum interpositum meningioma. So, we are taking this out, the debrider, you can see it's crazy, but, but that's how, you see, it's eating it away. And you can see the third ventricle. You can start seeing the third ventricle now. And that is the velum on the roof of the third ventricle. You must understand that this patient is completely head down. So the velum is going to be also down. So that is the third ventricle. That is the third ventricle there, anterior third ventricle. So this tumor is based up. So we are taking it with the debrider all the way. I don't want to take the internal cerebral vein into my debrider. So once it comes to the velum, we have to stop. That's the third ventricle. So it's completely cleared. So this thing is just eating it off, and then we have, that is a velum. So we have put Surgicel there, and then irrigating that part. And you will see the post-op picture now. So you can see the entire anatomy. That's the post-op picture. Tumor is cleared. That is the Mitaka arm, and that is our endoscope screen. That is our navigation screen. That's a microscope. This is how we're operating on this tumor. This is our theater with the intra-op MRI and all the modern gadgetry in the middle of nowhere in Nepal. So after about 10 years, we've been lucky to get all this. That's a 3D screen for the fellows. So you have the navigable microscope, you have the O-arm there, you have the intra-op MRI there, and that's the team. You have us with us for some time. That's Sergi Cherno, that's my team. That is how we do surgeries. So thank you very much, guys. Right. So I think I stopped sharing now.
Excellent interactivity. I
Beg your pardon?
excellent interactivity.
I see. I'm stopping this now. Okay. Right. So now questions, and after that, Professor Goyal can take over.
Okay. Okay, questions from panelists or input?
Can I ask a question?
Go ahead.
Professor Ivan, thank you very much. It's an excellent presentation. I see that when you open the cavernous sinus, when you are clipping the meningoepiphyseal trunk,
Yeah.
the sinus is very dry. So I've seen one surgery during my residency when we accidentally perforate the true cavernous membrane, and the bleeding is very profuse. So what is the technique in that? Thank you.
The sinus was dry only at that time when I was showing you. The sinus was not dry to start with. See, the sinus, when you open the Parkinson's triangle, there's bound to be a lot of bleeding. So you don't need to worry about that. You just need to put a little bit of flow seal, or if you don't have flow seal, you can put small bits of Surgicel and not press too much, just a little bit of Surgicel, a lot of water, and just wait. And after some time, that part of the sinus will be dry. So accidentally, if you open, of course, you will have a lot of bleeding. Even if you open elective into the cavernous sinus, when there's no tumor, there'll be a lot of bleeding. Like yesterday, Professor Goyal was showing us a cavernous hemangioma of the cavernous sinus. That will also bleed like hell. But to get the cavernous sinus dry, you just need a little bit of Surgicel, not a lot of pressure. You don't have to panic. Just irrigate, put in a little bit of cavernous sinus, a bit, maybe a piece of gel foam, and just wait there. And then that part of the sinus will slowly, it'll take some time, but it'll be dry. I hope I answered your question.
Okay, more questions, comments? Don't be afraid, go ahead.
Anybody? Vlad and Professor Goyal's comments?
Yeah, nice approach.
Thank you, Vlad. Thank you. Coming from you, thank you very much.
You're welcome. That was a real beauty.
Professor Goyal is around?
Yes, I believe he is. So you ready to turn it over? Okay, I guess we'll move
Hi.
on now. We'll move on now to Dr. Goel. Welcome, Dr. Goel. Oh, I'm sorry, did I interrupt a
Hello.
question? Did I interrupt a question? Go ahead.
Hello.
Go ahead.
Yes.
Hello, guys. Thank you, Professor Ibe, for such excellent presentation. I just want to know when to choose if you have to do an extradural or an intradural enterocleidoid craniolectomy. It depends on the case or on the ability of the surgeon or whatever other reason.
Well, an extradural approach for an extradural approach in this kind of paraclinoid aneurysms, if you think that the rupture point is in contact with the clinoid, it's very, very risky. But if the rupture point, if you think is away from the clinoid, even if the aneurysm is touching the clinoid, you can go all the way. You can take out the whole clinoid. I prefer to do that all the way. I prefer to take the all clinoid extradural because I have the protection of the dura. If I don't have the protection of the dura, to do an intradural clinoid drilling with the aneurysm there, I am seeing the aneurysm, so I don't like it. So I would like to do all the hard work first, and then, take out the entire strut, everything. Like yesterday, I showed you another paraclinoid. This was this paraclinoid. I left the strut and the lateral clinoid to be taken out intradurally. But yesterday's, if you remember, I took out the entire thing, including the strut. I took out extradural, and then I could clip the aneurysm very easy. So I would prefer the difficult stage first, and then I can relax instead of drilling after exposing the aneurysm to drill. I don't like it. Some people like it so that they can see the aneurysm and drill. I don't like to see the aneurysm. As soon as I see the aneurysm, I want to clip it off.
Okay, go ahead.
I've got a question. Can I?
Yes, Vlad.
What's your proximal control in these?
Neck, Vlad, neck.
What is your proximal control?
Neck. I expose the carotid in the neck.
I see.
Yeah.
I see.
Yes. Always. I always do this. When there are transitional aneurysms, I have seen people who do this, and then it goes well. But if it doesn't go well, it is unnecessary heartache. So I don't want to do this. I always, whenever we have transitional aneurysms, we expose in the neck.
Okay.
Okay, Ike, do you want to introduce Dr. Goel, please?
Well, I will just hand it over to him. I would like to see his comments, and then let him take the show over.
Okay, very good. Welcome, Dr.
John.
Goel. Welcome, Dr. Goel.
John,
Yes.
just give me a few minutes. Okay?
Okay, no problem. Go ahead. Okay, Ike, just keep rolling, I guess.
Okay.
Okay, more questions or comments from the panel? We've got a few minutes here.
Yeah, Professor, I just wanted to ask.
Go ahead, Khalid.
The cadaveric specimen on the cadavers you use. Do you source them locally, or you import them like some of the countries?
Well, we have a medical college, so we have cadavers ourselves, but these are not fantastic cadavers. This is why, unlike Pablo, I did not go into the brain part of it, because for our cadavers, the brain is literally nothing. It's just mush. But the skull base is intact, so I can see any amount of skull base. It's locally. So we have a dissection lab. When you guys come here, you will see that we have a dissection lab, and almost every month we have at least 2 or 3 dissections.
Okay, thank you.
Well, I can see Professor Goel's presentation. Even if that Professor Atul Goel name was not there, I would know, because he's put Chiari formation instead of Chiari malformation. So I know it's him. Nobody else does that. Right. So let's hand it over to him. Okay, guys, thank you very much.
Thanks, Ike.
Thank you, Prof.
I think it's the bottom right, Dr. Goel, the bottom, far right in the bottom, I believe. Is that, maybe someone can help them.
Yeah,
This one here.
Yeah, does anybody know which can help Dr. Goel out there with that WordPress interface? We got you, we don't have your audio, Dr. Goel, either. Okay, well, one
Now
issue.
you
I
can,
think,
Yeah, we can hear you now. Yeah, we can hear
you
you
have my
now.
audio?
Yeah, now we do.
yeah. Now we can have, we hear.
Okay. Sorry for all this. But now you are ready, John, completely?
Yes, we're all
Yes,
ready.
we are ready for you.
Okay, let's begin the show. I am going to talk to you on a very fantastic subject. And that subject has been of my great interest for a long time now. And that subject is on Chiari malformation, as you know it, malformation. And I have labeled it differently as formation. And believe me, my dear friends, I'm going to present to you a revolution, a complete revolution on the subject of Chiari formation. And be prepared to get into this revolution. And I will like to show you a number of slides to let you know how I have come to this revolution. So Chiari malformation, as it is known, Chiari malformation, but I have renamed it as Chiari formation. So this is Chiari malformation, if you like to call it now. So Chiari malformation is a common clinical subject. And Chiari malformation is present throughout the world. There are Chiari societies in America, there is a Chiari society in China, and there is Chiari society in England. There is a Syringomyelia society. So this is a very common subject, Chiari malformation. And if you would really like to know, I can give you one sentence that everybody knows how to treat Chiari malformation, but nobody exactly knows what is Chiari malformation. So I will like to discuss this. So this is Chiari malformation. This is Syringomyelia, which is very commonly associated with Chiari malformation. And this is Syringobulbia. And you must see several of my slides here of cerebellum. And I want to give you one quick information that I have identified that posterior fossa is not tight in this situation. Basilar invagination is a common association. So basilar invagination, Chiari malformation, Syringomyelia is a common clinical triad. So you will see this quite often. The question is, when there is basilar invagination, is Chiari malformation and Syringomyelia a different entity? And when there is no basilar invagination, is it a different entity? So that is one question that you should keep in your mind. You see, this kind of atlantoaxial instability and Chiari malformation is rather uncommon. Chiari malformation is in a chronic situation. This kind of atlantoaxial instability is rather an acute phenomenon. You will very rarely find manifest atlantoaxial instability in association with Chiari malformation. Chiari malformation, Syringomyelia, and no craniovertebral junction anomaly. There is no basilar invagination. there is no bone fusion, and there is no platybasia. So there is Chiari malformation and syringomyelia without any bone malformation. So it is a complex subject. Nobody knows why there is Chiari malformation. Why the tonsil herniates, nobody knows. The understanding is that there is a tight posterior fossa. The understanding is that the cerebellum is formed in an unusual and unnatural manner. So it is an embryological problem, like tonsillar herniation, uncal herniation. Uncal herniation and tonsillar herniation are completely and entirely different issues. But the problem is the name matches, and there is a, when you see tonsillar herniation, there is some kind of an urgency in the understanding of tonsillar herniation and the treatment. But tonsillar herniation is much different. It is a chronic event. And as I will show you more and more slides, and I have several slides to show you, I have to let you know that tonsillar herniation is a natural protective maneuvering, and it protects this part of the spinal cord against compression by the odontoid process against this bone. This is my concept. Now you see this beautiful slide. It says that basilar invagination, syringomyelia, Chiari formation, and they are all related to atlantoaxial instability. So this was my article. This is another article which says that is Chiari a formation or a malformation? So I have discussed in this article that it is not a malformation. It is a natural protective divine intervention to protect the human body against manifest or potential atlantoaxial instability. If you see in the literature, Chiari malformation is treated by a number of methods, and all these methods involve foramen magnum decompression. Some people recommend suboccipital foramen decompression. Some people like to remove the arch of atlas. Some people like to do C2 laminectomy. Some people like to open the dura. Some people like to open the arachnoid. Some like to remove the tonsil. Some like to put a tube in the obex and into the syringomyelia cavity. So everybody in the world, believe me, everybody in the world has some kind of a different technique of treatment of Chiari malformation. The problem is everybody knows how to treat Chiari formation, but the problem is nobody really understands it, despite the fact that it is more than 100 years since Chiari had described this problem. The confusion remains quite rife in the understanding of Chiari malformation. And I have to tell you that the answer is here now, and there is no confusion, and absolutely no confusion. This was my article which I had written in the year 2013, as I have shown you in my previous lecture. Is atlantoaxial instability the cause of Chiari malformation? At that time, I had 65 patients in the year 2013. Now, over the period of time, I have got a huge number of patients, including, as I mentioned the other day, the president of another country. There is no confusion in my mind. And I want you young people to listen to what I'm saying and come to a conclusion, come to a situation where you have no confusion, and that is the purpose of my lecture today. I want to discuss with you another absolutely revolutionary concept in the treatment of craniovertebral junction. And that concept is that there can be instability without any radiological abnormality. There can be symptoms without any neurological compression. So these are the two absolutely revolutionary concepts which I'm going to present to you. One is that there can be atlantoaxial instability without radiological instability. Second is there can be neurological symptoms and critical neurological symptoms without any compression in the context of Chiari malformation. So to explain this concept, I will like to go back in the historical perspective as to how I have developed this concept. And I want to give you that radiological imaging is not the only thing. Clinical understanding, an absolutely perfect clinical understanding of the situation is mandatory. And also I am putting several articles of mine for you to go back and read, because all these articles will be on the net once I finish this lecture. So craniovertebral junction is a very difficult subject. It is a dangerous subject. If you do not know, please do not touch it. Because you can create a devastation, you can kill the person, and you can absolutely, it is not a joke. The complication that you can have after craniovertebral junction surgery will be a complication that you have never had in your lifetime of spine surgery or neurosurgery. It is not an easy operation. On the other hand, if you do it properly and you do it beautifully, you can give a new life to this gentleman. He can now walk, he can have a very nice and productive family life. You can give a beautiful new life to this person. If you do not understand it, try to understand. It is a complex subject. You can give new life to this young boy and you can have a competition with him. You see his hand and you see my hand. You can have a real competition. You can have a person with neck becoming straight, and you can have a person where there is a beautiful smile. Again, I am repeating to you, you can give these unfortunate people an absolutely new life. And there is no place here to have ego, to have pride, to have hyper-confidence, to have a situation, no, I don't believe, I don't understand, and I don't. If you do not understand, please try to understand. Please grow up in your understanding, and you can have beautiful new life with an absolutely divine smile. And after the operation, you can ask this boy, have you got a new life? Not only this boy will say yes, but the whole family around standing around him will say, doctor, you have given us a new life. To that extent, it is important for us to understand. And also you must remember that these are common clinical problems. When we enter into the subject of neurosurgery, we are here to treat such complex situation. More importantly, we are here to understand these complex situations. We are not here to show our ego, we show our pride and show our hyper confidence. So I'm going to try to show you and try to explain to you my philosophical concepts about craniovertebral junction and the human spine. You see, this is the human spine, and this is a pillar, and this is the V of the Y. This V is the thing which is supporting the roof. This V is supporting the roof. Similarly, the human pillar, this V of the human pillar supports the head. Occipito-atlantal joint is the most mobile, is the most stable joint of the body, whole body. It is the most stable. Atlantoaxial joint is the most mobile joint of the body. So mobility and stability are the hallmarks of craniovertebral junction. There is huge circumferential mobility, and there is an absolutely strong stability of the craniovertebral junction. As I showed you the other day, atlantoaxial joint is a round and flat joint. It gives you an option of circumferential movements. There is no other joint except sacroiliac joint which is as flat as this. Even sacroiliac joint is not as flat. It is a flat joint. It is loaded by muscles. Transverse process of C1 is the largest transverse process of the body. Spinous process of C2 is the largest spinous process of the whole body. The facet of C1 is round, and facet of C2 is round, and the facet of C2 is the most unusual facets in the whole body. C2 is the atypical vertebra. There is odontoid process here. There is superior facet is in front of the inferior facet. Inferior facet is behind and not in line with the superior facet. And the vertebral artery comes in relationship to the superior facets and makes the introduction of C2 screw a complex surgical procedure. Understanding of the anatomy is the key issue in the understanding of the craniovertebral junction and to perform surgery in this region. Atlantoaxial dislocation or atlantoaxial instability is the most common instability in the whole spine. So we had introduced these 3D models for the first time in the literature, as I mentioned the other day. There will be some repetition of my slides, so please bear with that. I want to come to the point as to how I got the idea of Chiari malformation is an atlantoaxial instability problem. 3D models are very critical in complex situations. It gives you the location of the vertebral artery, it gives you location of the pedicle, and it gives you the situation as to how you have to enter into the atlantoaxial joint. If you can open the atlantoaxial joint, if you can remove the articular cartilage, if you can introduce the bone graft in the joint, only then you try to do craniovertebral surgery. If you cannot, you should not do atlantoaxial fixation surgery. Craniovertebral junction instability is equal to atlantoaxial instability. Craniovertebral junction, unstable craniovertebral junction means atlantoaxial instability. Craniovertebral junction stabilization means atlantoaxial stabilization. Occipital stabilization is not necessary. It is a suboptimal kind of fixation. So my 3 steps of operation are absolutely critical for me to do this operation. Open the joint, denude the articular cartilage, and introduce bone graft within the joint. These 3 steps are the most critical steps. I know I am talking to a very young audience here. My dear young friends, if you can do this, you have to do all these 3 steps or do not do this operation. As I have mentioned that the complications of surgery are the most dangerous complications in our entire subject. Do not do it. And if you do it properly. Suboptimal fixation is not a good treatment. Inclusion of the occipital bone, inclusion of the subaxial bones is a suboptimal fixation. So this was my first case, and now we are doing on a regular basis. As I mentioned last time, in 1 year, 2019, we did 250 cases of this kind of selective fixation. And over the period, we have more than 2,500 selective atlantoaxial fixation. So this was the first case in the year 1988. Now over the period of 32 years and more, our experience, I have learned to live with craniovertebral junction. And believe me or not, it has been quite a fantastic and quite an effective journey for me. And I can say I have given new lives to the people. And it is that kind of satisfaction. I have given new life. You can believe that satisfaction in a doctor is the most astounding satisfaction that one can ever get in the field of medicine. You see this atlantoaxial instability, and there is a compromise of, there is a syringomalia here in a young child. This was an infant, less than 1 year old child. There is spina bifida, C1 arch is bifid here in this situation. I cannot show you. And there is no other technique but the lateral fixation of the facets, which is the most beautiful technique for fixation. So atlantoaxial fixation, C1, C2 fixation, open the joint and do C1, C2 fixation. That is biomechanically the most astounding technique of fixation. This is another child. You see this child, there is spina bifida, C1 bifid, anterior arch bifid. And I had mentioned to you the other day, bifid is not an embryological problem. This is a divine solution. You do flexion, the bifid opens, you do extension, the bifid closes. And there is a possibility of movement from front, possibility of movement from back. Whenever there is bifid posterior, there has to be bifid anterior, because otherwise the possibility of movements is not there. So whenever you see bifid, even if the patient is asymptomatic, you need to do fixation, and atlantoaxial fixation is the treatment. You will not know probably this, because you may not know. Occipital screws were first described by us. Occipitoaxial screws that include C1 was first described by us. But this question is, occipitoaxial fixation, is it necessary? And I wrote this editorial in the year 2010. I wrote and I mentioned that occipital bone inclusion in the craniovertebral junction stabilization is a suboptimal form of fixation. Don't do it. However, in some situations where you cannot do, when you have gone to do C1, C2 fixation and you cannot do, there happens some situation, there can be some arterial problem, there can be venous problem, there can be some anatomical problem where you cannot expose. In that situation, you might just like to do, but I must tell you, for last 20 years, I have not done occipital fixation in my surgical curriculum. And I can say for sure, for me, occipital inclusion is a historical operation. As I told you the other day, the most important revolution in the field of craniovertebral junction was this article, which was published as cover page of Journal of Neurosurgery, where we said that there is nothing like fixed atlantoaxial instability. You open the joint, you can reduce this fixation. And there are several cases now with me, hundreds of cases like this. In fixed, you can open the joint and reduce the dislocation and then do fixation. Earlier, we used to do transoral surgery on a very regular basis. Now, transoral surgery is an absolutely And I will repeat again, transoral surgery by nose, by mouth, by any kind of surgery, by removal of this odontoid process is for those people who do not understand this subject. And if I have already repeated to you, if you do not understand, do not do. You do not play with these patients. Open the joint, reduce the dislocation, and then do. This is an unstable situation. This is not a fixed problem. Reduction of the dislocation is mandatory. This is another case of fixed atlantoaxial dislocation. You see, it is fixed. Transoral decompression may be one treatment which is historical. But you see, there is a beautiful option of reduction and realignment of the craniovertebral junction. The problem is, the question is whether you can do it, whether you can open the joint in this situation. You can argue with me, no, this, that. Question is not argument. I am not saying from a high pedestal. I am talking to you at equal eye-to-eye contact. Transoral surgery is not required in this situation. Learn the art of opening the joint. Learn the art of manipulating the facet, and you can do. You see, there is no space here, and there is space here. This is another beautiful case. You see, on flexion and extension, there is quite a bit of atlantoaxial instability. The facets are in this situation, and you see postoperative facets in complete alignment, facets in complete alignment. I will again repeat for you, again repeat. It is not the deformation which is important. It is not the realignment which is important. Stabilization of this unstable segment is an important step of surgery. This is another case of fixed atlantoaxial instability. There is bifid anterior and posterior arch. When I see and posterior arch is bifid, I don't have to even see the anterior. It has to be bifid. The facets are in the most unusual situation. Go along the pedicle, open the joint, manipulate the facets and realign the facets, and you can have a complete realignment of the craniovertebral junction. More importantly for us, for you, is the patient, and that I can tell you, this patient will get a new life in the evening of operation. You will have never seen the smile on his face like you will see in the evening of operation. You have not seen the smile on the mother's face like you will see in the evening of operation. Another type of dislocation is rotatory dislocation. Nobody in the world knew how to treat rotatory dislocation. This art of opening the joint and manipulation of the facet can give beautiful new life, not just cosmetically, but functionally. These patients will get absolutely a new life in the evening of operation. Now you see some of these patients, you see the neck which is completely deformed and rotated. Now I have got several patients who come with only symptom of neck rotation and neck deformity and torticollis. And there is one option that you say, I don't want to treat it. There is another option is you treat it and you give new life. These are dangerous issues. These are absolutely dangerous issues. You can create a neurological deficit in a person who has come walking to you. In a person who has come with the only symptom of neck deformity with not even pain in the neck. But there is a possibility of giving, even now there is some kind of deformity, but now it is a stable problem. This is another situation. You see the neck in a completely 70-degree movement here, and you see the neck rotation, and now you have a person, this beautiful girl, having completely, not only just the cosmetic, I am telling you, this person has got a new life. This boy you see from a village farmer's child, and you see the very tremendous kind of abnormality in the neck, and this is after surgery. The smile is not so prominent, but his hands and legs can hit you with a very big force. When there is disruption following injury and disruption, there is a complete disruption of the facets. There is a possibility of manual alignment in traumatic atlantoaxial instability. So these were the spacers that we had introduced, and I mentioned to you the other day, I don't use spacers in all the cases. In some selected cases I use. Now comes the issue of basilar invagination. We divided basilar invagination into two groups. One is when the odontoid process goes in, and one when the tonsil comes down. So this is a Chiari malformation. One is when there is odontoid goes in, and the second is when there is a tonsillar herniation, or when there is a Chiari malformation. So presence of Chiari malformation made me divide this, and this is a very highly referred article. In the year 1998, we said that these patients need transoral decompression, because we thought ourselves that this is a fixed problem. And for the young people who are listening to me, I must tell you that in 1998, nobody actually knew what is basilar invagination. There was one very prominent article which was mentioned that basilar invagination should not be treated. But I can tell you, basilar invagination, you treat, you give new life, absolutely new life. Our concept was at that time that these are fixed problem and decompression is the treatment. You do transoral decompression here and foramen magnum decompression here. That was the treatment. Chiari malformation is treated by foramen magnum decompression, and this is treated by transoral decompression. In this era, in this paper, I wrote that basilar invagination and Chiari malformation, there is a small posterior fossa, and I said that there is no need to open the dura after bone decompression. This is in this article. And the role of fixation was controversial in my article. And this, when there is, in the year 2004, we said that there are two types of basilar invagination. This is associated with an unstable spine, and this patient needs treatment by distraction, and craniovertebral realignment was the new term introduced in the world of spine. This was an absolutely dramatic revolution. Those who know this craniovertebral junction know this article and know this concept very well. In 2004, for this group of Chiari malformation, I still said, I must tell you, still I said that decompression is the treatment in 2004. So basilar invagination, treatment by craniovertebral junction realignment, basilar invagination by treatment by craniovertebral junction realignment, basilar invagination by realignment, no decompression from front, no decompression from behind. This was my first case after 2000. In the year 2000, we did this without transoral surgery. We were doing transoral surgery on a very regular basis before this. So this was the odontoid process, and craniovertebral junction realignment was described as a complete revolution in the field of craniovertebral junction. Basilar invagination, see the facets, difficult to open the joint, complex to open the joint, complex surgery. These are complex surgery. There is no other word other than complex. But if you do it properly, C1 screw, C2 screw, open the joint, you can give absolutely a new divine intervention for this person. There is unstable spine, there is basilar invagination, you do Chamberlain line, you do Weckenheim-Clivel line, you do Macrae's line, you see the facets in a very abnormal situation, you open the joint, you realign the facets, you realign the craniovertebral junction, an absolutely revolution in the field of craniovertebral junction. When I show you this thing, I must tell you that for the last 30 years, I am having fellows from all over the world, and many of my fellows are doing this treatment. But still this concept, if you read the American literature, the concept is complete. You see the Western literature, they do not still understand this concept. We said a beautiful article, a philosophical article, we said that basilar invagination is like C1 over C2 listhesis, like you treat C1 lumbosacral listhesis, you treat basilar invagination, and that is the treatment for basilar invagination. Basilar invagination, very beautiful case. When I see this case, I immediately become so highly excited, and because you will ask me why you become excited. I become excited that I now have a possibility to give new life to this person. I now have a possibility to give a new life to the whole family. It makes me, my hair becomes, they become absolutely like a rigid hair and straight hair. When I see this patient in my outpatient, I become happy. And I must tell you that I have a possibility of giving beautiful new life. So this is the facet, difficult to expose, complex to expose, but difficult means nothing for young neurosurgeons. Even brain tumors are difficult. Even CP angle is difficult. Difficult word you go on using in your lifetime. What difficult? Difficult means you have to do. You have entered into a subject of neurosurgery. This is not a subject which is going to deal with easy things in your life. Like you saw anterior clinoid aneurysm. It is not easy. If you have to do, you have to do. This word difficult should not be in our dictionary. You see this basilar invagination, you see group A basilar invagination, sometimes it is associated with Chiari malformation. And if you say that there is Chiari malformation and I will do foramen magnum decompression, I will say you have done an absolute disaster for this patient. And I have to tell you, my dear young friends, many people in the world, when they will see this Chiari malformation, they will say, okay, foramen magnum decompression, foramen magnum decompression. What foramen magnum decompression you want to do in this? There is no need for foramen magnum decompression. The facets are in a completely malaligned situation. You have to do craniovertebral junction realignment, and this person will get a new life. There is no need for decompression in this case or in any case. There is another case like syringomyelia. You will say, I will do syringostomy. I will say, what nonsense, you leave neurosurgery and you will be giving more benefit to your patient than operating and doing foramen magnum decompression in this situation. Believe me. And when I'm using such aggressive tone, you must remember that I'm telling you what I feel is the best for our patients. This is the patient, you see, there's a complete realignment and there is no need for any kind of syringostomy or any kind of foramen magnum decompression. No foramen magnum, this is not a tight posterior foci. You see the subarachnoid spaces are so wide and beautifully seen. This is another case. You see there is the whole odontoid process has gone in. The facets are in a completely shattered situation. There is a possibility of completely realigning. It is, again, I want to tell you, it is not realignment which is the matter. It is stabilization of this area. Instability is the issue and stabilization is the treatment. Another case of basilar invagination and there is some tonsillar herniation. Do not do decompression from front or from behind. Realign the person, do beautiful C1, C2 fixation. Basilar invagination of a supreme kind. You see, there is no give him beautiful new life. Not him, but the whole family. Make him productive. Have this understanding, have this philosophy. Don't have confusion. Don't talk unnecessarily. Don't argue unnecessarily. Believe me, when I said about this in the year 2004 and 2001, I was giving lectures on this subject. I was very badly ridiculed by a number of neurosurgeons all over the world, to the extent that I was criticized to a great extent when I said this. Now, unfortunately or fortunately, that those people have gone into wilderness. You see, this is a basilar invagination. You treat and realignment. There is no need to do decompression for Chiari malformation. There is a need for doing a beautiful stabilization, and that is the treatment. So in my department, in the history of my own life of neurosurgery since the year 2000, 20 years, I have said now that transoral surgery is a completely historical operation. And I have no hesitation when I say that I made this operation historical. You will, young people, you will not believe that in the year 1995, 2000, 2005, 2008, in every neurosurgical meeting, this transoral surgery was a hot topic for discussion. There were session after session on transoral surgery. Now there are no sessions. Even in this year 2005, you see there is Chiari malformation here. I wrote this article in the year 2005 for Chiari malformation. I said that realignment is the answer for Chiari malformation in the year 2005. C1 over C2 listhesis is the issue, and craniovertebral junction realignment is the treatment. So now 15 years, my concept is that Chiari malformation, no decompression is the treatment, and syringomyelia should not be handled. Now, as I showed you the other day, I want to show you in a little bit wider perspective that when there is atlantoaxial instability, the nature comes into picture. God comes in picture. There is divine intervention, nature. God who has made you, who has made the human being, knows how to protect the human being. Atlantoaxial instability occurs in the pediatric, in the fetus sometimes. And during the act of delivery of the child, instability occurs, and the nature is now saying, oh, my beautiful creation is in problem, and that glory of God comes in the picture, and God now tries to stabilize the human being, and there are various things that God does to stabilize the human being. Short neck, torticollis, all these musculoskeletal abnormalities which I was talking to you the other day are divine interventions to protect the human body from negatives of craniovertebral junction instability and death. There can be death due to craniovertebral junction instability. God protects, makes you protect from the dead body. When there is a disc herniation, there is a scoliosis. That scoliosis is not a negative endeavor by God. Similarly, when there is an atlantoaxial instability, there is a short neck and torticollis. This is not a negative procedure. God is now trying to protect. So God is all in its all glory and wonder and divinity when atlantoaxial instability occurs in a chronic kind of a situation. These children are chronically unstable children. Stable children with neck straight. So neck torticollis, shortening of the neck. Musculoskeletal abnormalities. When you see short neck, when you see torticollis, immediately that idea should come into your mind that this is not normal. God has not created an error when he has made this child. Torticollis was not born. It has happened as a protective maneuver, and it is God is protecting to an extent, but then starts symptom of hand weakness, leg weakness, and various other things that happen. And you do stabilization and everything returns back to normal. This boy, you see, this boy is not just compression. He's living with this compression, and these kind of torticollis and short neck are helping him. to tide over this problem. Atlantoaxial instability is the foundation for all these issues. So when you see a short neck, when you see a torticollis head, you must remember that you have an atlantoaxial instability at hand, and you need to stabilize this child. You need to stabilize this child to give a long neck, and you have to give a new, beautiful, handsome child and a new life, not only to this child, but to the whole family. You see an unstable spine, and then you do a stable spine with fixation. These are not easy operations. Believe me, these are difficult operations. But if you have an idea in your mind that I will do occipital fixation, I will do subaxial fixation, you go with a mindset which is not a good mindset, you can create disasters. Believe me, you can create disasters this time. You cannot do it, don't do it. But if you have to do it, you have to do with great confidence of C1, C2 fixation. And you see this child in the immediate postoperative period, you will not even recognize this child with the neck being so long. And these are the traction on the head which I have used. And this is in the immediate postoperative period. And if you see, there is a subtle, nice, wry smile on this child face, but you have not seen the smile on the mother's face and on the father's face. Fusion is not an embryological problem. Cervical fusion is a protective natural response, and it shows you that there is an unstable craniovertebral junction. Bifid is not an embryological problem. Fusion indicates atlantoaxial instability. Bifid indicates atlantoaxial instability. This is a case of bifid anterior and posterior arch. You see the smile on this face and smile on my face, and you see this patient completely cured, new life. Patient with multiple, this patient was known to one politician, and he introduced me to politics. He introduced me to newspapers. He made me quite famous. This patient came with a person came, you see the child in a devastated situation. This patient is not exactly a child, about 20, 21 years old girl. When she came, this was a very complex situation, and I told the father that this is a difficult operation. Your daughter can die after the operation. But by the time she came to me, she was not even able to tell her name to me because she could not speak. And after the surgery, you can see the confidence in her eyes and confidence in her face. And believe me, the father has become like my disciple. I don't want to be on a high pedestal. Believe me, I am giving this lecture to young people, not on a high pedestal. I am telling you, we have an opportunity to give new life to these children. Let us try to learn this. Let us not try to argue foolishly and with arrogant head. This is another patient. When she came to me, she was almost not breathing, but the patient's father said they will like to wait before they will like to take a decision on surgery. So craniovertebral junction is a complex issue. Chiari malformation can be a common event. Basilar invagination, syringomyelia, and Chiari malformation is a common entity related to atlantoaxial instability. They are the son of the same father, and the father is atlantoaxial instability. We have to treat the father, take care, and all these three are the children. Syringomyelia is also a child of atlantoaxial instability. Do not treat syringomyelia. You treat syringomyelia, you harm the person. Now I will go to a very important revolution in the subject. I hope you are not tired. So what I'll do is I'll take a break, and I will just like to see your faces, okay?
Okay.
I will like to see your faces.
Okay, let's introduce some of the panelists to Dr. Goel. Would someone like to say hello to Dr. Goel?
Yes, I want to listen to some voices and I like to see some faces.
Okay.
Hello, Dr. Goel. It's from Bangladesh, Dr. Salek.
No.
Yeah, I'm going to take you off the screen there. Stop your screen share for a second, Dr. Goel.
Hello, sir. This is Dr.
So
Uday.
you can see the faces. Okay, go ahead, sir. Go ahead.
Okay, John, let me go further, okay?
Okay.
Sir, I'm Dr. Sharath from Jodhpur. Sharath Thanvi.
Yes, yes. Okay.
Okay.
Okay, what we'll do is just mute yourself now. Let us complete it and then we will open this for questions. I have still a long way. Just relax. If whenever you are tired, John, and whenever others are tired, you let me know.
No, you inspire us. Keep going.
Okay. Now I will talk about a revolution, complete revolution in the field of craniovertebral junction. And that craniovertebral junction revolution is called central atlantoaxial instability. It is expanding the horizons of craniovertebral junction surgery. It says that there can be atlantoaxial instability without radiological manifestation. And this central instability is associated with not only craniovertebral junction problem, and in my subsequent lectures, you just hold on to see a complete revolution in spine surgery. My dear young people, just hold on to see a revolution in the treatment of OPLL, in the treatment of spinal degeneration, and in the treatment of a number of deformities. Just be prepared and be excited enough to see the revolution. And I will show you the revolution. So this you know already, that there can be C1 over C2 like basilar invagination. But now I am going to show you a facetal alignment and a different classification, as I touched upon the other day. So this is C1 over C2 listhesis, that like basilar invagination. In this situation, there can be atlantodental interval disturbance. And believe me, for last 50 years, this is the only, not only 50 years, even now people have only one parameter. Atlantodental interval disturbance is the only parameter to identify atlantoaxial instability. Basilar invagination group 2, nobody till date, I can tell you, nobody in the world till date will not do foramen magnum decompression in this situation. Nobody in the world will do any other operation other than foramen magnum decompression. Believe me, and you know it, many of you are senior people here. So this is basilar invagination. You see the facetal malalignment. The facets are malaligned and this patient does not need decompression. Believe me, my dear friends, this patient needs atlantoaxial stabilization. It is not an easy operation to open the joint in this situation. Is not easy. It is quite high. To open the joint is difficult, but if you can do it, you give new life. Now I introduce you to the third thing. Even when the facets are in alignment, even when there is no atlantodental interval disturbance, even when there is no tight posterior cranial fossa, this is an unstable situation, and you do, even the Chiari malformation and syringomyelia are clear indicators to you, clear, absolutely clear indicators of presence of an unstable atlantoaxial joint, and you need to do atlantoaxial stabilization, and you give new life to this person. If you say, my dear friends, I will do foramen magnum decompression for this patient, why you want to do foramen? There is no tight posterior fossa. This patient needs only one treatment, believe me, and that treatment for the whole world, I am saying. Today, the whole world will do one treatment for this patient, and that treatment is foramen magnum decompression. And I have no hesitation to say with great confidence that the whole world is wrong. And the time has come for the whole world to understand and change. If you do not want to change, believe me, my friend, you are wrong. And I will now show you why you are wrong. This is one type of dislocation. This is atlantodental disturbance. You know that this needs fixation. This is basilar invagination. You know that this needs, you do not know till now, but you know now that this patient needs atlantoaxial stabilization and new life. Chiari malformation, facetal malalignment. You see the facetal malalignment. I can tell you, if you do foramen magnum decompression in this patient, you create a disaster. You may not report it, but your patient is never going to improve. He will say, doctor, okay, I'm okay, but he will never be improved. And you do, there is no atlantodental interval disturbance. There is facetal malaligned type 2. You do atlantoaxial fixation. You do give new life to this patient. And this I will show you by several examples. Huge basilar invagination, no atlantodental interval disturbance. See the facetal malalignment, do atlantoaxial fixation. So now my concept is very clear. In the year 2012, my concept is that all basilar invaginations are unstable and all of them need stabilization. So even if there is group A, you need to stabilize. Even if it is group B, there is stabilization. So my dear young friends, I'm giving you one statement. Basilar invagination, there is no need for decompression, whether there is group A or whether there is group B. All these patients need craniovertebral junction stabilization. And craniovertebral junction stabilization means atlantoaxial stabilization. Basilar invagination group A with Chiari and Syrinx. See the facets in a very dramatic situation. You need to do craniovertebral realignment and fixation. You see the syringomalia and you see the syringomalia gone. You see the tonsil will herniate up. I mentioned to you, I do not want to talk about syringomalia going or not going. I am giving you one sentence that this patient will get a new life. And that new life will be not just an ordinary improvement in tingling or ordinary improvement in spasticity. He will be cured completely or magically. A new life this person will get. And don't argue with me in a stupid way. I will do foramen magnum decompression for this Chiari malformation. I will introduce a Syrinx shunt. Do not argue with me in a stupid way. There is Chiari malformation. There is no atlantodental interval disturbance. There is a huge basilar invagination. There is some malformation in the facetal alignment. You do, this is not an easy operation. My dear young friend, this is not easy. Do not take home the message that, oh, very easy, I will give new life, I will give new child, I will give new family. If you have to give, yes, you can give. But you have to do this in a very beautiful manner. Even when there is assimilation of atlas, even when there is C2-3 fusion, multiple fusion, there is no need to include the occipital bone. You get to the facetal articulation. You will say, I will do occipital. Go on doing. There is no need, even if you learn this procedure direct, open the joint, do three steps of the operation, open the joint, introduce bone into the facetal articulation, and then do fixation. Now I ask you the question, is atlantoaxial instability the cause of Chiari? Whatever questions you have in your mind, I do not just want to hear any question. Atlantoaxial fixation is the treatment. And now I'm going to give you several cases to show you what I mean. See, there is Chiari malformation here. I am using malformation all the time, but I am wrong. I should use Chiari formation. This word will not go out of my mouth. This word will not go out of your mouth, because we are used to talking malformation all our life of neurosurgery. You see, there is this no real abnormality, and there is a treatment of atlantoaxial stabilization. There is Chiari malformation. There is no tight posterior cranial fossa. There is no atlantodental interval disturbance, but there is a facial malalignment, and atlantoaxial fixation is the treatment. No foramen magnum decompression. No atlantodental interval disturbance. There is a facetal malalignment. There is no real basilar invagination. There is a syringomyelia. You do atlantoaxial fixation. You see syringomyelia has gone, and this patient has got a new life. That you have to hear from me, and I will show you some videos if I can show you. Basilar invagination, there is facetal malalignment, there is Chiari malformation. If you say, I will do foramen magnum decompression, I will say, go on doing, my dear friends. Go on doing, and you will create absolutely unfortunate people you will create. Do this beautiful operation, and you will create a wonder. This is the syringomyelia. There is Chiari malformation. There is big basilar invagination. There may not be. This is central atlantoaxial instability. There is no atlantodental interval disturbance. You see the syrinx is gone, and syrinx is reduced, and there is no atlantodental interval disturbance. Chiari malformation and huge syringomyelia. No atlantodental interval disturbance, no facetal real malalignment. You see atlantoaxial fixation, and you see the syrinx is gone. There is no bone removal here. There is no dural decompression. There is no bone decompression. A revolution in craniovertebral junction, a revolution in neurosurgery has been made. Whether you agree or whether you do not agree, my dear friends, it is made. I got multiple letters to editor, multiple letters from editor saying that, no, I don't believe, I don't believe. I said, okay, don't believe. What I can do, I cannot break my head. I cannot tear my clothes. I cannot run naked on the fields. I can only show you some cases. You see, I'm again telling you, my dear friends, you please pardon my language. I'm not talking from any high pedestal. I am not trying to be out of the world. I'm showing you cases. I'm showing you, you have the possibility of doing this. You see, there is syringomyelia, there is Chiari malformation. There is no unstable here. If you do foramen magnum decompression, you will not do any great help to this patient. There is an unstable spine, and you do fixation and see the syringomyelia is gone. There is big Chiari malformation. There is no facetal malalignment, no atlantodental interval disturbance. Atlantoaxial fixation is the treatment. There is another case with syringomyelia, no atlantodental interval, and fixation is the treatment. This is, sorry, the same case. This is another case. You see, there is Chiari malformation, there is syringomyelia, and this is immediate postoperative. I will tell you, you do this operation, and next day you do MRI. In about 10% of cases, you will get syrinx reduction. And in 100% of cases, after 1 year, you will get syrinx reduction in 100% cases. This is another case with syringomyelia and Chiari malformation. Don't do anything else. There is a facetal malalignment. You see the syrinx has reduced and the tonsil has gone. You see there is no compression. The tonsil has gone up. After 1 year, 100% cases, you will get syrinx reduction. I must tell you, my dear friends, wherever I go, people ridicule me. People talk unnecessary things to me. In various internet, I have given this lecture in more than 100 times in the world. All Chiari, I have been invited. They invite me all, of course they invite me, but they are not still agreeing. The whole world is not agreeing. I ask you one question. Can you do C1, C2 fixation? If you will say, yes, I can do, then you will agree with me. The question is, to do C1, C2 fixation in a case of Chiari malformation is not easy operation. To do C1, C2 fixation in a case of syrinx is not easy operation. To do C1, C2 fixation in a case of basilar invagination group B is not an easy operation. If you cannot do it, you say, no, it is not a good operation. If you will be able to do it, yes, then you will say, yes, it is a good operation. Multiple for my article. Also, I'm saying whatever statements I'm making are all heavily published in the literature. And I had to respond to various questions in various ways in the literature. You must read some of these things. Most important question was that Chiari malformation needs may be unstable when there is basilar invagination. So I wrote this article, even when there is no craniovertebral junction abnormality, there can be atlantoaxial instability, and atlantoaxial stabilization is the treatment. And all the articles which I'm showing you are in very high profile journals. You see, this is Chiari malformation and syringomalia. There is no atlantoaxial instability and there is no basilar invagination, but you see there is a facetal malalignment. There is no craniovertebral junction bone abnormality here, but there is a facetal malalignment. There is Chiari malformation and syringomalia. You do atlantoaxial stabilization, the syringomalia disappears. There is no basilar invagination in this case, but there is a subtle instability. You do atlantoaxial stabilization and you create absolutely new life to the person. You will, these patients, many of these patients do not breathe properly. Do you know Chiari malformation patients come with sleep apneas because they stop breathing during sleep? Do you know that these patients cannot talk loudly because they cannot breathe properly? Do you know they cannot run because they cannot breathe properly? Do you know they cannot sleep in supine position? You know why? Because they cannot breathe properly. Have you ever asked this question to your patients, whether they can sleep, they are in what position they are sleeping? Have you asked the question that whether they are getting sleep apneas? You will get in at least 50% patients, they will be having sleep apneas. They will have giddiness. They will be having visual issues. They will have some strange kind of issues. You do this and you give new life to this patient. And I am telling you, I am getting patients from all over the world. I have recently treated a president of one country. And now, whether you agree or not, you go, don't agree. I don't bother, but of course it took time for people to agree. Now I am having patients from all over the world to do Chiari malformation treatment, because the problem is nobody knows how to open the joint. You young people should know how to open the joint. There is Chiari malformation with C2-3 fusion. If you say I will do decompression, I will say you don't discuss with me further. There is Chiari malformation. There is no atlantodental interval disturbance. There is no atlantodental interval disturbance, but you see the facets in a tremendously malaligned situation, and you have to do a beautiful C1, C2 fixation, and you see the tonsil has gone up. I'm again saying I don't bother about tonsil going up or not. I bother about the patient. The symptoms will go for sure. Another case of Chiari malformation, no problem here. There is little bit disturbance in the facetal malalignment, and you do fixation. Another question you will ask me, in the presence of C1 assimilation, why not do occipital fixation? My dear, don't do these kind of stupidities. Don't do foolishness. You do direct C1, C2 fixation. Open the joint, introduce bone graft. Of course, when you cannot do, suboptimal you can do, maybe you can get over it, but when you do a long implant, you can never stabilize the C1, C2 joint in that fashion. And suboptimality should not be in your books. You see the syringomalia, Chiari malformation, syringomalia reduced tonsil up, and the patient improves quite dramatically. Another patient, syringomyelia reduced, and there is fixation. Another syringomyelia, see the facetal malalignment, and you see the syringomyelia reduced in the immediate postoperative period, and there is C1, C2 fixation. Syringomyelia in present Chiari malformation. If you say to me, my dear friends, I will do syringostomy, I don't have hair. If I had hair, I would have torn my hair. If you say now that I will do foramen magnum decompression for this, there is no need to do foramen magnum decompression. You do fixation and the syringomyelia will disappear. Similarly, in this case, this is another case, syringomyelia disappear. Another case, I think I showed you this earlier, syringomyelia disappear. Syringomyelia reduced and fixation. This is another case. No, this I have shown you earlier. Now you see this patient, this is not a dramatic improvement I'm showing you. I'm not showing you a dramatic improvement, but just see this. This patient is walking, and this patient here, I'm not showing you a dramatic improvement, but some improvement. Unfortunately, this video is not running in a very nice fashion, but he's walking much better now. This is immediately in the postoperative period. Now, I am getting several patients from all over the place where foramen magnum decompression has been done for this. You see, foramen magnum decompression has been done, but this was ignored. So now I did C1, C2 fixation, and you see the syrinx has reduced and the patient has dramatically improved. That you have to take my word. This is another case where foramen magnum decompression was done, then syringostomy was done. This patient underwent 13 operations. Lumboperitoneal shunt was done, ventriculoperitoneal shunt was done, then decompression was done on several occasions. This patient underwent 13 operations. See, the joint is normal. I do fixation and I give new life to this person. This is the patient. You see, there is a syringostomy tube here, foramen magnum decompression, and this gentleman was a poor farmer and an educated farmer. You see the situation, there is a Riles tube here. He cannot even lift up his head. There was a catheter here. He's not able to stand. He's not able to do any procedure. This is an IIT doctor, not IIT, PhD in IIT, which is one of the very high institute in our country, a farmer by occupation, their parents. And this patient, when he was going out of the hospital, you see he's sitting on the wheelchair, and you see his head, and you see his hands. You see he's stabilizing his hands here. I can tell you this not only, and his back in his IIT. He's got a new life. You see his hands now, he's walking in his village. You see his hut. I don't want to repeat again and again. If you have to just see this, you can start crying. If you don't cry, you're not a real human being. You see foramen magnum decompression, multiple times decompression, and did C1, C2 fixation. Even then, this patient had not improved, but because this fusion was not a solid fixation, I removed this. Then I introduced bone graft in the facet joint and did solid fixation again. And this patient dramatically improved. This was fixed, but the joint was not dealt with to my great satisfaction. When I reoperated, the whole thing was not fixed properly. So you have to do properly, fix properly and tightly. If you have to do decompressions in these kind of situations, you can create only kind of adhesions and all those kind of things. And there can be syringomyelia which can be born after your multiple traumatizing arachnoidal handling in this situation. So when you have a syrinx and syringomalia, even when there is a normal, do not do foramen magnum decompression. Now I am having multiple cases where even my own cases where I had done foramen magnum decompression. So I have to tell you, the other question that was asked to me by various people, you see, by the Pediatric Craniovertebral Junction Society of the North America. And you see the number of authors that wrote to me saying that, no, it may be good for adults, may be good for deformed patient, but it is not good for pediatric patients. So then I wrote another article where I showed in 33 pediatric patients. Now I have over 50 pediatric patients where I have done. You see, this is a pediatric, this is a child, and this is syringomalia and Chiari malformation. I did fixation. I gave new birth to this child. If I can show you a video, you will just love this. You see, this is a, unfortunately, these videos are not. Okay, now you see. See this patient, this is a child not walking very nicely. Now you see the child is running. And if you can see the smile on the mother's face, you see that smile on the mother's face? This is divine, this is godly smile. This is another child who had been treated, you see, in various kind of unusual manner. And this is a fixation. This is another child with Atlantic, this Chiari and syrinx and being treated. This is another child with C1, C2 fixation, and you see the syrinx has gone. No, this is, I have shown you already. This is an adult. Yes, this patient. This patient already underwent several operations. I have a patient who was a radio singer and a musician. After the operation by decompression, she lost her voice completely. The voice was lost. A musician losing a voice. And this musician had come back to beautiful, back to radio after this C1, C2 fixation. She was not able to even walk properly before surgery. You see, she's holding, and this is not, I am not showing you dramatic improvement cases. I'm showing you some little bit example, which I'm showing you whatever I'm showing you, and just you can get the glimpse of what, but what you can see is the beautiful divine smile on the face of this person. This smile, if you want to see, you see the trouble on the face and you see the smile on the face. My dear friends, you can give this smile to our patients. Don't do decompression. Don't waste your time. Don't argue unnecessarily. This, that, this. Don't do all this kind of foolishness. Learn to do C1, C2 fixation. And you see this young girl, how the face was. And if you see the face now, you can see an absolutely brand new face. You see another small young boy, you see, and these are how he's walking. And now you see that beautiful, what beautiful smile on the face. Yeah, wow. My dear friends, beautiful smile. Oh my God. When such people come, I just don't want to hear the world. My world of craniovertebral junction is here. You see another, this child I showed you actually, and this child is in my hand. When they come, they treat me, I don't want to use that word, but they keep me in their family. I am their family member. They keep me in their life. And this is another young child. Now, if you want to argue with me, no, this treatment is only for children and no, only for adults and only for children. I can only pity you. I can only pity you. Believe me, again, I must say, I am not talking from any high pedestal. I'm talking on a very normal situation. Unfortunately, I am not able to show you that video. This is another child, the syrinx has gone. Idiopathic syringe, my dear gentlemen. Do you know what is the treatment of idiopathic syringe? You do not know because nobody in the world is knowing. I can tell you idiopathic syringe, the treatment is C1, C2 fixation. You give new life. Kyphoscoliosis. You know this kyphoscoliosis, if it goes to an orthopedic surgeon, what they will do to this kyphoscoliosis, they will introduce 300 screws in all the 300 screws and a kilometer of rod. But do you know what this needs is? This needs C1, C2 fixation. And you see this spine before operation, after operation, and this boy is jumping with joy. All his symptoms have gone and there is no question. We did intraoperative motor evoke potentials, intraoperative. Intraoperative improvement in motor evoke potential. You see recovery of transcranial after in the operation theater. Don't have doubts, okay? Don't have doubts. Don't have stupid doubts. Have reasonable doubts. If you have doubts, I can give you one answer to that. Come to my department. I have got people from 27 countries, more than 250 observers who have seen this operation. You also come. You are no different. We are all students of our great subject of neurosurgery. You come and I will show you. Can foramen magnum decompression surgery become historical? I say, no question. Historical already. Is Chiari a formation or a malformation? I want to ask you, young people in the audience, old people and experienced people in the audience, is it a malformation? I say, don't break your head unnecessarily. It is a clear formation. Basilar invagination, syringomalia, and Chiari malformation is not a great word. Atlantoaxial instability is the cause. And these are all natural protective maneuvering. And I give you thanks for me and for my dear wife who is here in this picture. And I hope you have enjoyed my journey with craniovertebral junction. And I am sure you have enjoyed it. And if you have not enjoyed, I cannot say what to say. So John, now field is open for you.
Okay, great. Thanks, Dr. Goel. Okay, the floor is open for questions. If you have a good connection, you can ask the questions orally. If you do not have a good connection, just text them and we'll try to get them to Dr. Goel. Okay, the floor is open.
Atul?
Yeah.
Go ahead, Vlad.
Atul, how do you do the distraction during surgery? The traction during surgery?
Yeah, that is another beautiful thing, my dear Vlad. Nice to hear your voice. And I'm very happy to hear your voice, Vlad.
Me too.
I hope you enjoyed my presentation, Vlad.
I did, as always.
Thank you very much. And
Thank you.
As you can know, this distraction, that is the key to the surgery. That is the key to the entire process. Open the joint. Learn the art of opening the joint. Remove the articular cartilage. And then, just a minute, Vlad, just a minute. I want to see the participants. Okay, now, can you, John, can you?
Yeah, let me get you off the screen and start again here.
Yeah.
Okay, start from square one now. Well, there you go.
Yes, now I'm there.
Yeah, just
So
start.
Vlad, the main thing is.
I'm sorry, you're not on it yet, Atul. You got a screen share. You fell off.
Should I share the screen?
Yeah, you need to share the screen.
Okay.
There you go.
Okay.
Okay.
So what I have to say is, blood, to open the joint, that is the trick. That is the whole game. And that is the whole problem. If you can open the joint, if you cannot open the joint, you have to learn, my dear Vlad, you have to come to my department if you want to see this trick of the trade.
I wanted
And you are
to.
you are not an old man, you are a young man.
Sure.
You cannot say, I know you very well. I know how enthusiastic you are, my dear friend. I know you. You cannot say, I cannot do it. And you cannot ask me how you do it. You know, you will learn it, you will come to me.
Certainly.
Yeah. Yes.
Okay, more comments, questions?
Yes, questions.
Okay,
Yes,
go ahead.
Hello.
Go ahead.
Okay, recently we have sent one patient, 8 years old girl, to Professor Goel. Probably the baby has intractable sleep apnea. She just came back this corona issue, before the corona issue. She's doing well. And just it's for
Not well, not well. You tell me that she has got a new life. Tell me.
hello.
You have to tell me that she has got a new life. If you
Yes.
absolutely, you ask her questions properly. How is your sleep apnea? How is your breathing? How are your hands? How is the tingling in your hands? How are your legs? She will say, doctor, I have got a new life. I have no doubt about it. I don't know which patient you are talking about, but I know that she has
This
got
patient has gone from Dhaka CMS, Bangladesh Military Hospital.
Yes.
Yes. You can remember.
Yeah,
Thanks.
now I remember. Yes.
Yes.
Dr. Salih. Yes.
Thanks for everything.
Thank you.
Hello, Dr. Atul.
Hello. Go ahead.
Thank you so much for this great presentation, as usual. I'm asking about the investigations for these kind of cases. Should I order the CT cervical craniocervical junction in all the patients, or I do have a criteria for that?
No,
Thank you.
now I will answer that question. You see, these are very complex operations. These are very dangerous operations. And you have to do all the investigations in the world. You have to do CT angiography, you have to do MRI, MR angiography, and in complex cases, you have to do 3D model. I do very elaborate investigations for all my patients. You cannot say I will avoid CT. I do also, I have to tell you that many of my patients are very poor people. But poor people means I cannot compromise on my investigations. I do all the investigations in all the patients. There is no way I can compromise on investigations. So that is my answer to your question.
Yes. Thank you so much.
Thank you.
Then you have a question?
Hello, yeah. Hello, Professor Atul.
Yes.
First of all, very thankful to you, and hello, Professor. Hello, Professor Atul.
Yes, I'm listening.
He is here? Okay.
Yeah.
First, my name is Dr. Adnan. I am from King Edward Medical University, Lahore, Pakistan. And I am fourth year resident, still way more to go. First, I came to know about you, sorry, very late, a bit, because I was not so familiar with a lot of famous names in world. But one of my professor who recently joined as a AP here, she told me about we had one patient of carry malformation, sorry, this terminology, attend to axial instability patient. And she said, she shared one of your paper of 2009, which you have published in May-June 2009 in Neurology India journal. It was about that carry malformation, and you have divided in group 1 and group 2. And group 2, for
Yes.
group 2, you have advised that posterior fossa decompression can be done, and it's a good result in 2009. Then
Yes.
I was discussing this, and she told me that you have to hear him. If you you will hear him, you will never forget the way. You will be very impressed by him, the way he speaks, the way he convinces the things. And still from that time, I am very very big fan of you. And when you have given recently a presentation in Pakistan, PSN webinar with Dr. Salman Sharif, I was there. And Dr. John always encourages everybody for the young neurosurgeon to join the great giants of neurosurgery like you, sir. And
Thank you, Adnan. Thank you.
my concept also changed about that atlantoaxial instability, and it's all because of you. And I want to thank you a lot.
Thank you, Adnan. Best wishes to you. You must become a very big neurosurgeon, okay? Bigger than anyone else, Adnan.
Okay, there's a couple of questions in the chat box. Can you see the chat box, Dr.
No, I cannot see. Can you get for me, please?
Yeah, okay. How
Can I ask a question, please?
Go ahead.
Yes. How do Professor Atul Gol? Thank you very much for your great presentation. I'm Dr. Jalal Najjar from Syria. I want to ask you something about the main issue of this presentation or this approach. Usually we see during maybe the 20 years ago, we see all the doctors, they make their arguments about the treatment and the way to treat and the way to fix and how is it anterior approach or posterior approach. So the argument is about the treatment, but you do your argument now about the pathophysiology and the etiology of the disease itself. How can you explain for us for this shifting in argument, please?
So I have given you 2 hours lecture, my dear friend, giving you the entire history of my development on this subject. And I will come back to you. I have another lecture on this subject. I will not leave you till I give you complete information, till I completely convince you. I will come back. I have another lecture on this, on craniovertebral junction and deformities and other things. I am going to show you. In any case, how are you, my dear friend? How is Syria? Is okay?
Oh, yes, it's okay. We are on the border between Syria and Turkey till now.
So you have to
Thank
come,
you.
invite me to Syria, and I want to see Syria, and I will come with my friend Vlad to
You
see
are
your
welcome,
great
sir.
country. And I had some wonderful friends in Syria. I hope they are all right. I am not in any communication with them now.
Yes, surely, inshallah. You're welcome. Okay, thank you.
Thank you.
Okay, one question, Dr. Goel. What is the plan of management if C1 lateral mass is fused with the occiput?
Yeah, that is a question which is very important question, but I have told you in my lecture whether the C1 is fused or whether the C1 is not fused. My 3 steps of my surgery involves opening of the joint, removing of the cartilage, and introducing bone graft in the joint cavity. So that 3 steps cannot change. And if the 3 steps change, then it is a compromised situation. I have told you that I do not do occipital fixation for 20 years in my department. I am now removing the occipital implants, which I had done several years ago, because the stability that C1, C2 direct fixation can give you, occipital large infarcts, the large implants can never give you. And large implants are suboptimal fixation. So even if C1 is fused, you have to do C1, C2 fixation. When C1 is fused, the C1 is more solid. The condyle and C1 make a bigger, thicker bone, and you can introduce a huge screw, 28 millimeter, 26, 28 millimeter length screw you can put. Occipital screws, I told you that occipital screws were described by me. I described occipital screws first time in the literature. But now I am saying I described all right, but I don't like to use because I have found a better option, C1 screws.
We have a question here, Doc. How frequently do you see vertebral artery anomalies?
I am going to talk on this vertebral artery anomalies in one of my lectures very soon, and how to control the vertebral artery when it is injured. And I'm going to show you, more importantly, how to do C1, C2 fixation. I'm going to show you by video. Unfortunately, I'm waiting for my internet connection to become better, and I'm going to talk to you daily for 1 month. So if you be prepared to see this, and I'm going to show you not only craniovertebral junction, I'm going to show you a revolution in spine, revolution in degenerative spine, revolution in treatment of lumbar spine, revolution in the treatment of cervical stenosis, revolution in the treatment of lumbar stenosis, revolution in treatment of spinal kyphosis. You be prepared. You promise me that you will join my seminar every day for 1 month. I will change you. I will change your concept. That is my promise. And I will show you how to handle the vertebral artery.
Very good, Doc. Dr. Uday Gupta asks, in a case of Chiari with normal facetal alignment, should we do a C1, C2?
Of course, you have to do C1, C2. And John, by the time in 1 month, I will make you a good neurosurgeon yourself.
I'm almost ready now. Dr. Haifez asked, for how long do you apply the collar?
Yeah, collar I apply for a period of 3 months after the surgery. I take iliac crest bone graft, and I will, if possible, the video didn't run even good today, but if they run properly, I will like to show you the technique of insertion of bone graft in the joint, the technique of insertion of bone graft in the craniovertebral junction, and I want to show you how to handle the vertebral artery. I will show you how to mobilize the vertebral artery. I will show you how to drill the facets. I will show you how to drill the bone to introduce your screws.
Okay, Khalif, you have good audio. Why don't you ask that question to Dr. Goel?
Go
ahead, Khalif.
Thank you so much, Prof. Thank you so much. My question is,
I hope, Khalif, you are enjoying it.
I enjoyed it so much. Thank you so much. Greetings from Mombasa, Kenya.
Okay, Khalif.
The question is, we had some few patients, we did a posterior fossa decompression, and unfortunately, they got worse. They got worse symptoms. One of them, unfortunately, died. We think it was related to the positioning. That was our explanation, that we didn't have monitoring at that time. So we thought that when we were positioning the patient in prone position, that was the cause. But from what I'm getting from this lecture is that there will be no need to do posterior fossa decompression for these patients at all, even when we don't see basilar invagination.
So you take Khalif, you take my
Yes.
message to Mombasa.
Yes.
And
Yes.
you take my message to Kenya. Okay.
Yes.
And
Yes.
your patient worsened. You see, when I was a resident and I was appealing for examination, I was supposed to answer that what you will do for Chiari malformation. My answer should be that I will do foramen magnum decompression. The other question is what you will tell the patient and the relatives. You will tell the patient and the relatives that I am doing this operation not to improve you. I am doing this operation to stall the progress so that it does not worsen. That was the answer I was supposed to give. And if I don't give this answer, I would be not passing my examination. Now, Vlad will agree with me. Vlad, what do you think? This was the...
Atul, exactly the same. Exactly the same. And then you had to tell that the patient will deteriorate again after some 2-3 years.
That's right.
Yeah.
Vlad knows
It was
this,
crazy.
that is the thing. That was the whole world was doing like that, Khalif. So don't worry if you just take my message, you think about it. I'm not saying take my message and just start doing this. Take my message, think about it, and if possible, do it when you become a more senior, more solid, more strong, and your hair disappear or your hair become gray like others in the pictures. Okay.
Thank you, Prof.
I've got a
Thank you so much.
Hello.
Yeah.
Go ahead.
Sorry, I have another question. I'm sorry, I didn't introduce myself firstly. I'm Rania Swera. I'm from Sudan. I'm a third-year surgical resident. My question to you, in fact, Dr. Guel, is about the fascinating work of research that you are doing. Can you tell us more about the time and how you distribute all these things between surgery and research? That would be a great addition to us, as we all know that not written is not done. So the research is a really important thing in our life. Thank you.
So I'm showing you by example. You see the example and you be stimulated. That is the purpose of this lecture. Purpose of this lecture is to stimulate young people like you. And you must know that I am not giving lecture. Many of the people in the audience are young residents. So I am giving this lecture to young residents to stimulate you, to stimulate you to write, to stimulate you to think, to stimulate you to work, and to stimulate you to concentrate and work hard on this subject. This is a beautiful subject. Neurosurgery is a divine subject. Neurosurgery is the greatest subject on the planet. You give new life to the person. On the other hand, you kill the person. So you learn to give new life. You learn on cadavers, you learn on anatomy, you learn on patients. You become better, you think, and if you get a new idea, you publish it. You publish it. You must read several of my articles that I'm showing. So you see that example and get stimulated. Go home and get stimulated and write and work and think. So that is from Sudan. I'm happy to see you. And I'm sure Sudan you will be a good neurosurgeon of Sudan and future big neurosurgeon of your great country.
Thank you so much. You have a great fans here, and they all say to you hi. So, and we hope to see you soon.
Well, you know what, Phil, we had grand rounds in Sudan for a while. How's Moshe doing? Moshe, is that the gentleman's name? In Sudan?
Yeah, yes, his name is Mujahid. Yes,
okay,
yes, he's doing great.
Tell him let's start grand rounds again from Sudan.
Okay, I will.
Say hello too.
Thank you, Dr. John, for your great efforts. Thank you.
I got a question for Professor Goel.
Go ahead.
Professor Goel, sir, are you sir listening me? Hello?
Yes, I'm listening. Yes.
Sir, I am Uday, sir, calling you.
Yes. Tell me.
Sir, the take-home message for today was that those patients who do not have any atlantoaxial instability, but they had a syringomyelia, and you try to fix C1, C2 joint fixation. Sir, for the another part, I did lots of, not as many patients as you must be doing, but the patients whom I have operated with foramen magnum decompression, and they are given, they are still under my follow-up, and they do come with the not very great symptoms of like they were having in the pre-operative period. So what should be the turning point when I should turn them that now, because I did only a foramen magnum decompression in my initial operation, I want to go for a C1, C2 fixation now?
I will tell you, you know what, Dr. Uday, the whole world is still doing foramen magnum decompression, okay?
Yes, sir.
And if you see, they are happy with the operation. Many of them are happy with what they are doing.
Yes, sir.
Now, many times I go and give this lecture, they ask me this question, that I have been doing foramen magnum decompression and the patients are improving. This question they are asking me, and they are asking then how. But if you see the literature, if you read I have read quite extensively the literature. If you read the literature carefully about foramen magnum decompression and the results, see the results, you will see that 15 to 50% failure rate is there in foramen magnum decompression. You read the literature. When you go, back to your computer, you read the literature on various people have written on this. That is one. The second thing is the extent of improvement. You see, so many times in my lecture, I said, the patient will get new life. Patient will get new life. You see with what confidence I am saying new life. See, when you have just marginal recovery here and there, even, when you suture your muscles, you are stabilizing the person. When you give, you take an incision, that pain itself will stabilize the craniovertebral junction. For sometimes that pain and that muscle suturing will stabilize you for 1 or 2 months, you will be all right. But after 2 months, you will be again down. See, that is the thing. Now I'm giving you a concept. You think about it. You read various articles I have put on the screen. You go and read. You are a young boy. You have to improve in your thought process. You have to go further in your life. We are dealing with humans. We are dealing with very nice human beings. You think about it. Get convinced about it. And if you are convinced about it, and if you are not convinced about it, you are, KEM Hospital, Mumbai is not far away from you. People are coming from all over the world. They are coming. What is your problem? You have no legs or you have no money to travel. I will give you money to come to my hospital.
Sir, I have been a regular visitor of your hospital, sir, and I have been
I'm
attending.
not telling you, Uday. I know you. You are a very enthusiastic young boy. I know you. I'm talking to others that if you have any issues, or if you have some confusion, I'm doing free workshops. You know, Uday, these workshops are free of cost. And my observer position is completely free of cost. If you have confusion, there is an option of coming and spending some time. So don't get restless, and so go and see the literature and see what has been done. But I can tell you clearly and without confusion, a revolution has been made in this field. And I will also make one little bit egoistic statement. There is no other revolution in the last 20 years in neurosurgery bigger than this revolution.
Oh, yes, sir.
You think about it, okay?
Perfect, sir. Thank you, sir.
Thank you. Thank you, Uday.
There's one question. Can you answer if there's a contraindication for C1, C2 fixation? What are the alternative solutions?
According to me, there is no contraindications, but there are some situations where you have a problem in doing this operation. There is no contraindication. And how to handle a situation where you cannot open the C1, you cannot expose the C1, how will you handle that situation? How will you handle the situation where vertebral artery is in a very dangerous situation? How will you handle that situation? And I have kept one lecture for you on that subject, how to handle difficult situations and how to get over in those situations of vertebral artery issues and other issues. Anatomical issues are there, exposure issues are there. So I will discuss in a subsequent lecture. You come and you spend 1 month with me at least on the John Bennett's program, and I will show you how to handle this, okay?
Yeah, you can put your name in the chat box if you want information from Dr. Atul. Okay, Matthias Costa asks, how many patients with scoliosis have you treated with C1, C2 fixation? And which kind of scoliosis do you apply it for?
See, scoliosis is a big subject, is a huge subject. I'm also kept one more lecture on deformities, on cervical kyphosis, deformities, dorsolumbar kyphosis, lumbar scoliosis, lumbar lordosis, all this deformity. I have kept one lecture. I will talk on this subject.
Okay. Okay, more questions, comments as I scroll through some of the other possible questions. Let's see here. Yeah, I was just telling people all these lectures are available on the YouTube channel of Neurosurgical TV in case you missed some of it. Do you use, Dr. Haifaz asked, do you use skull traction in complex cases?
Skull traction, yes. Skull traction I use in all the cases, only during the operation, not before operation, not out after operation, all cases during operation.
Okay, let me see. I'm scrolling, see if okay, I don't know if you had this question before. Anterior C1, C2 fixation, better or posterior C1, C2 fixation? Any specific indications for anterior fixation?
I do not recommend anterior fixation. I do not do anterior fixation. Anterior fixation is a suboptimal operation. If you have to touch craniovertebral junction, learn to do the best operation, learn to do the difficult. Posterior is a difficult operation, but posterior is a biomechanically a solid operation. You cut the muscles of C2 when you do posterior. Muscles of C2 are very strong muscles. There are too many things about posterior. All the muscles of the neck are located posterior. There is not a single muscle located anterior. All the activity of the muscles are going on from the posterior direction. If you have to demolish those muscles, if you have to demolish the craniovertebral junction and stabilize the junction, you have to remove those muscles. From front, there is only one thin layer of muscles, longus colli, that is also not a muscle. You are coming from front directly on the bone and stabilizing without handling the muscles. I don't think, and also I don't want to argue too much on front or back. I'm absolutely convinced you have to do a posterior operation if you have to do it properly.
Go ahead, Dr. Salik, do you want to ask that question? Well, go ahead, Dr. Sharad, go ahead. You're on there. Okay. Dr. Salek from Bangladesh asked, do you consider anterior retropharyngeal approach?
I don't consider it a good approach. I don't want to discuss this further.
Okay.
I don't consider it a good operation. I don't consider it the best operation. For the craniovertebral junction, you need the best operation. You don't want to do any kind of a suboptimal operation. I must tell you that I introduced clival plates from front. From the mouth, I used to do clival fixation from clivus to C3. I introduced first time introduction of bone graft in the facet joint from the front, from the transoral route. I did C1, C2 fixation from the mouth. I did all those things 25 years ago. I have left those things completely.
Okay. Okay. Do you, Dr. Haifaz asked, do you use skull traction in complex cases?
I answered this question, John.
Okay, I'm sorry about that. I missed that. Let's see here. What else we got here? I don't know if I asked this either. Okay. People have requests for videos. Well, I think that's pretty well covers most of the questions I've got. I'd like to thank you for a great educational session for everyone, I'm sure. And tomorrow, Doc, do you have the topic?
I will give you the topic soon, John. I will
Okay.
think about it and send you the topic soon. Okay?
Very good. I'd like to thank you, as well as all the panelists, I'm sure would like to thank you. And we'll see you tomorrow.
Thank you, John. Thank you. Bye-bye.
Thank you. Thank you.
Thank you, Atul.
Thank you.
Enjoy. John.
Okay, hey, how you doing, Vlad?
Thank
you very much.
Stay
Thank
over
you.
a bit. Can we try to share the lecture?
Yeah. Let's do that right now. Good. I'm glad you came. Let's do that right now. Let me get your videos, and everyone watching. You're getting it, and you're not paying for this. You're getting to see Vlad go over his videos for a presentation.
No, that would be without videos because videos will not go through in a.
Oh, do you want to go through the videos, or what do you want to do?
No. Just the lecture. I guess that it will be. What is Atul's connection? Is it any good or is it the same as mine?
Well, you want me to put your PowerPoint up, or is that what you want me to do? Or
Yeah.
what? Okay, and then we'll go through it to make sure it goes smooth, okay? Yeah, let me get this settled here. I've got to, hold on, just give me a second. Here.
Share.
Okay. Yeah, it'll take a minute to find it.
Yeah. Where do I have the share screen?
Yeah, I'll get that in a second. Hold on.
Yeah.
I'm going to get the link for your original. Just looking for that link. Okay. Okay, I got the link. Okay.
Mm-hmm.
And I'm going to share the screen with you now so that we pick the right files. Okay, now you want me to go to the
Yeah, this is the original one. So
okay, let me go to the PowerPoint. You want me to go to the PowerPoint now?
No. Can we go to again to my? I don't know whether this is this the recent or is this the one I gave you a while ago?
No, a while ago. This is the one that your associate sent the link of all the.
No, that's not it.
So let me go down.
No, that's not it, John. That's somewhere
okay.
else.
Okay, that's the only one I've got from you.
Oh, that's the only one you've got.
Yeah.
Did I send it to you or did you open it in my computer?
I don't recall getting another link, another.
Can you now hook up to my computer?
That's possible, but I don't do it normally. I've had people come in and go into my computer.
Okay. So I should try to send it to you some way.
Yeah, send it the same way that you sent those.
I will over the week. Okay,
yeah.
Son. Perfect.
When are you scheduled to do your lecture?
I guess I have spoken to Salman. I don't know, how are you connected with Salman and his lectures? It is the same link, but I do not know if it's organized by someone in Karachi, a young guy called Imad.
Yeah,
and
yeah.
They asked me for AVMs on over the next week.
Well, you didn't present, you moderated, didn't you, in that conference?
I moderated 3 or 4 days ago. I don't remember, but
yeah.
No, they asked me to give a lecture on AVMs.
Oh,
and
okay.
I believe this is going through you because it is this the same link.
No, I'm not arranging that this year or this series. I'm televising them, but not arranging them. But yeah, Ahmad handles that. Do you have his email address? Did you want to send him the file?
Yeah, he's Ahmad.
I will. I
can share his phone number.
Yeah, okay. Vlad, there's a gentleman there that knows Ahmad from Pakistan.
Yeah, I know.
He's a technician.
Yeah, I know.
Oh, you know him.
So you can
I have his mail and I will send it to him and.
Text his email address on the
I
contact.
have Imad's email address. I just I'm unable to send it from home and I'm not good at it.
Just send him the link.
One of my residents must do it. I'm unable to do that. Okay.
Okay. Sounds good.
Sounds good.
Yeah.
John, just not to make any social upheaval. What is the relation between yourself, your TV, and this Salman's, this Imad guy?
I televise his events. For the last 3 years, we've televised conferences from Pakistan.
So there is no competition.
No. What the way he gives me his videos and I show him, like his series that he just did. he's doing now for Pakistan.
Okay, so if I just give a lecture,
yeah, he's sending me the link, and I'm putting it on also on Neurosurgical TV.
Very
I'm
good.
also putting it. So he's
Very
not
good.
only doing his own.
Okay.
I'm
Okay, I
taking
just
his.
wondered about other relations because I
No,
didn't.
no. I televise events all the time, and I
Okay.
televise his events now. I televise you moderating a couple days ago.
Yeah.
When you caused that big problem there, but I won't go into that. No, I televise that too. So you know, he just lets me know, and I tell it. It's like being a TV affiliate. They may make a program, but I take their program and put it on my site also. It's not competition. We're trying to broaden the audience for what he's doing.
Right. And the audience in both is the same, or is it?
Yeah, it's the same audience. It's the same
audience.
Yeah,
Then
most
it's
people
okay.
aren't interested, but we're just televising it in another place.
Okay, John.
So no
No
problem.
problem with me. I'll send some of the lectures to you, some of them to Salman, and it doesn't matter where I will give it then.
Okay.
Am I right?
Yep, that's fine.
Good.
Yep, that's good.
Okay.
Enjoy.
Okay, thanks, Vlad, for coming.
Thanks.
And thanks everybody else. Does anybody else have want to introduce themselves or say anything?
Yeah.
I think okay.
And John.
We'll see you tomorrow, and Dr. Atul, and I'm not sure if I've been speaking or what, but we'll let you know. So thanks everybody for coming.
Thank you, Dr. Bennett.
Thank you,
Bye.
Dung from Nigeria. Thank you.
Bye bye.